Hello. Sí.
Good morning, everyone. Hello. I hope you all had a good night's sleep and we are all ready to go ahead with our second day deliberations. I welcome all of you to day 2 of our meet on United Against TB, Accelerated Action Towards Achieving SDG on Tuberculosis, which is being jointly organized by, I'm repeating this, what I said yesterday, so that it remains fresh in your mind. It is organized by Global Call to Find All TB, to End TB, by TB People Zimbabwe, by TB People India, and by CNS, with support from Molbio Diagnostics. We have a series of very interesting sessions lined up for today, but before that, I would like to invite two journalists, Catherine Murembedzi, from Zimbabwe, and Zarina Gelu from Zambia, to please give a brief recap of day 1 proceedings. Welcome, Catherine and Zarina. The stage, or the side stage is yours now. Come.
Good morning, colleagues. Welcome to day 2. My name is Catherine Murembedzi from Zimbabwe. In our recap, it's going to be interactive so that we jolt our minds on what we learned yesterday.
Morning, everybody. My name is Zarina Gelu from Zambia. Well, let me introduce myself. Yesterday, I said Zambia had the 7th national wonder of the world, the Victoria Falls, and I was almost lynched. So let me recap again. My name is Zarina. I'm from Zambia, Christian nation, only Christian nation in Africa. So as Catherine said, the recap is going to be interactive. Yesterday, we had a very energetic session with Dr. Sahu, when he talked about being on TB-related SDG targets and what was needed to achieve it. And I think that he laid out very clearly what was needed. Lots has been done, but what more was needed? And maybe somebody in the audience can give us one thing that he said was needed. Now,
Yes.
I know you all
Anyone?
talk because yesterday we couldn't stop you from talking when we went to the lab facility. So you can't be quiet here now.
The Deputy Director of Stop TB Partnership, Dr. Suvanat Sahu, forgive me if I pronounce the names wrongly. He said we are off track, the SDG for ending TB. So we are here collectively to try and get the train back on the track. He said stakeholder commitment partnership, right? What is happening here today? This is what is needed. We'll go back to our countries, we'll implement, we'll continue to be talking. So anyone in less than a minute to say what they are going to be doing and what they understood from yesterday. Yes, you can say. Yes, sir. The mic, please give the mic to. Yes, there's the mic. Thank you to him.
No, he showed you the curve of decline in incidence currently, and how if we keep on doing what we are currently doing, we will not be able to reach the targets of sustainable development goals by 2030 or even 2035, the WHO targets. So what he said is that now we need to sort of do things more proactively, and he listed 5-6 things which need to be done. And those 5-6 things are: first, find all cases. And secondly, he said, find them early. Then treat all those who you have detected. Focus on prevention. So there was a stress on TB preventive therapy. And he said, look for partnerships. And in the end, yes, he gave a hope that you will soon have a vaccine. So these were the 5-6 crucial action which he listed out. So maybe one by one, you can take them up. So that's it. Yeah. Thank you.
Yeah. So he said that business as usual will no longer work. And it's not from here. He said business as usual will no longer work. We can't keep doing the same thing. Different results. And that we have to think outside.
During the COVID-19 era, can we then how they manage to have drugs right on time or ahead of time? Anyone to recap us on that? Yes, thank you, sir. Professor, just say your name to refresh our mind.
Yeah, but I don't know if it's related to what I will say now. It's related to the second talker, but for me, if I can summarize the day yesterday, I think there is a new concept that we need to change in our country, especially in Africa. with what we are observing now, we cannot anymore talking about TB control program. It's now TB elimination program. One of our main indicator is not only, I see for Goa, number need to be tested, but now is number need to be screened. That something should be important from this meeting. I can call it the Goa Declaration. Is it should be test again, linked to care, linked to nutrition support. So for that, we need more resources. And we need a strong leadership, advocacy from community, but also for the entire population. We need that this population have access to that.
Primary prevention begins in the communities, right at the facility. That is now treatment. If we are getting to treatment, we have missed something. We have missed prevention. So can someone refresh us on what India is doing? In Africa, we have a saying, we say, if you educate a woman, you have educated the nation. And I was glad to note that in India, it's similar. Can someone tell us about the community workers and how it's functioning in India? Yes, Bobby.
Yeah, okay. Well, we have people who are doing the real work, but in India, sir, please correct me, Dr. Chopra Sahab, Dr. Sachdeva sir is here, Dr. Khanna is here. So, community health workers are playing a very important role in bridging, in bridging the divide between the key populations of people who are at very high risk of TB, like homeless people, migrant workers, people who are in the shelter homes for homeless people, and in prison inmates, etc. Also sex workers, as Dr. Chopra sir had said, and connecting them to public services. So they get the molecular, best of diagnostics, like molecular tests, for example, X-rays, and same day test and treat has become possible in Dr. Khanna's and Dr. Chopra's centers in Delhi for the people who are not even able to stand up because of these community health workers. Frontline health workers are really very critical to, this is what I feel as a, this is my 2 bits, that to connect the most at risk people with the services which might be very, very close to them. This is very important. Also, it is very important from the equity point of view, because the people who are most left behind or most likely to be left behind are also getting the state of the art and best possible diagnostics and treatment if we have community health workers to connect them to these public services, but also in people-centered way, in rights-based way, and as Shobha had yesterday said, gender transformative way. So if we have people-centric responses, if we hear to the people we serve, we will get those answers. And that is what probably people sitting here have already done. We saw Dr. Bornali Datta's van. Best Diagnostics goes free, all free. The X-rays, you saw the portable X-ray on a motorcycle, or the molecular test machines, they go as close as possible to the people most at risk. very important initiative is Dr. Bonali Datta yesterday showed that she is also establishing, helping with you, support of you all, establishing a diagnostic and treatment facility in the homeless centers. I think, sir, two, if I remember correctly. Yes, sir, sorry.
No. Thank you. I think Bobby brought out a point of that community has brought in equity for people, but there are two more aspects to it. What the community engagement has done. First is advocacy. I mean, it's only through their advocacy and activism, I'll use the word activism, that you have brought it to the notice of politicians and bureaucrats. And they are sort of, you charge them to take decisions rather quickly. I mean, they are typically known to not take decisions too quickly. So you sort of shorten that timeline. You will agree. Yeah? So, I mean, to the extent possible. When that's one part, the huge advocacy on, say, there are new diagnostics, there are new treatment options, there are new drugs available. So that's where I think community also plays a huge role in creating a perceived demand for bureaucrats and politicians that it should be made available. That's number one. Also important is when there is something not going well within the national programs. So they will bring out to the attention of right people, which probably sometimes people in the system cannot do that, which is drug shortages. Who can make a hue and cry except community, or something is not available in some part of the country. Yeah. So these are also two very important functions which communities serve as advocacy. Also, in another way, program monitoring and forcing people to take corrective steps. Of course, Bobby, you mentioned about actual engagement with the community, which is the last mile actually. Before that, there are two other functions. Yeah.
Chopra sir was saying that initiative was good, but the thing was when it was in the prison, when prisoner releasing from the prison, that time all the documents are not there actually. So we have to work on that also. A document should after releasing that prisoner, spread this thing. Thank you.
Thank you very much.
Thank you very much. I'd like us to give like a round of applause to the community workers, the food soldiers. They are not on a salary, they just get a stipend allowance. So I think that is where we are starting from. Can we please just give a round of applause to them?
Thank you very much, everyone. I hope we're energized and ready for the next session.
Thank you.
Thank you, Catherine and Zarina. And I now invite Dr. Amar Niranjan Shah, the Division Chief at Tuberculosis and Infection Diseases at USAID India, to please do the honors of chairing today's opening session, in which some of our overseas guests will share their country's success stories of implementation of iNTP, that is Introducing New Tools Project of Stop TB Partnership and the USAID. Welcome, Dr. Shah.
Great. Really good morning to all. I think yesterday was an excellent day, and I'll also add maybe those who kind of joined the site visit for the More Bio kind of production factory. That was really good. And I think the word which we used after coming out was the state of the art. And that's so satisfying that and I think that is also inspiration for all the countries. Let's say we strive for this kind of state of the art facilities, which can kind of create tools and the products which can be kind of used for a larger. And in that sense, I'm really honored and very happy to kind of start with this session, which is on introducing new tools project. Shortly we called iNTP, which was kind of a joint venture from both the Stop TB Partnership and USAID. And we have excellent presentations to learn from those experiences. So to do that, maybe first I'll request Dr. Savanand Sahu from the Stop TB Partnership to provide the introductory address and the background of this project. Over to Dr. Sahu.
Thank you, Amar. Let me share my screen, and I'm glad to be back on the second day, and I very keenly listened to the feedback from the first day. So very interesting day, it seems. So I was not able to join there in person, but I am there both days. So I will briefly...
audio. Yeah. Now we can hear you, Dr. Sahu, please.
Okay. So I will briefly talk about this iNTP project. It is nothing but Introducing New Tools project. Let me at the outset say something that we all should, I think, reflect on. We all want new tools, but new tools don't self-implement. A lot of things are needed to make them accessible to people. Like people talk now about the people who are the real people in need, the people who are the most left behind people or most underserved people. The objective of this project was to make it available, these new tools, to make it available in countries, in selected countries, of course, but to the people who are underserved, not at the capital with the best laboratory, but really in places where people are in need. So thanks to USAID for a very generous contribution for this purpose. And we had great collaboration from Stop TB Partnership with USAID, not only at the global level, but also at the country level where this project was implemented. You will hear some more in-depth stories about these country experiences, but let me just summarize a few things for you. So this project focused on 11 high burden countries. I think 2 more got added as we got through the implementation phase. So what happened was these were the tools that were provided to the countries. 63 ultra portable digital X-ray systems to 7 countries. 63 systems for CAD, the computer, the AI-enabled systems for detection. 301 MolBio TrueNat systems to 9 countries. For TB infection testing, currently we have EGRAs. So EGRAs were provided to 3 countries. Then there was diagnostic connectivity solution for GeneXpert and TrueNat machines, which were provided to 5 countries. Digital treatment adherence support like 99 dots and video supported treatment was provided to 5 countries. Targeted next-gen gene sequencing was provided to 1 country. And TB preventive therapy was provided to 6 countries. Now, This happened in 2021, starting 2021. So about 3 years back, if you transport yourself 3 years back, these tools were not available in these countries. So these are the countries where this project focused. It was a total about 26.8 million US dollar worth of commodities. As the commodities were provided, they were also used, and a number of lessons were learned from countries, and which we tried to put in terms of webinar, some guidance on implementation, and many other tools that are currently available on the StopTB website for everybody to look at it. So this is about, so I will talk about the diagnostics, the experience on the diagnostics. The first one is the X-ray and the CAD AI software. So 7 national TV programs have worked on it with partners. 63 ultra-portable machines were provided, and these were of 2 makes, Delft and the Fuji X-Air. These were made available to countries through the GDF. So through GDF, countries can procure these 2 technologies currently. But GDF is also doing currently a expansion of that the catalog, and we soon expect more X-ray machines to be also available to countries through the GDF mechanism. This was the largest multi-country rollout of this technology. There has been other projects earlier to this, which were kind of a project in one country or a few countries, but this was the largest kind of systematic scale up in a number of countries. Now, the experience, we went through the implementation phase, and 430,000 individuals were screened with X-ray, and 14,000 TB detected. This is still ongoing, so the results are as of end of quarter 3 of 2023. All 7 countries already have plans for wider scale-up of digital X-ray, and Global Fund applications included the scale-up plan and the funding required for it. We have summarized the experience in practical guidance, a training module, and some case studies and webinars, which are available on our website. There is a page dedicated to iNTP on our website, and one of them is on the X-ray and CAD, and you will find all the experiences summarized there. I would encourage you to have a look at that website. Now, shifting to the TrueNat. After the WHO recommended TrueNat, 301 instruments were provided under this project. This is, again, the largest multi-country rollout of TrueNat technology. At that time, India had a large-scale implementation of TrueNat, but most other countries had no experience. I would say all other countries had no experience except for 1 or 2 projects somewhere. So this was the first use and large-scale use of TrueNat in a number of countries. And these countries used it in peripheral labs, and we also had 2 countries, Philippines and Nigeria, who used these machines in a portable mode, like some people were talking about what you saw yesterday. So on board vehicles, and the Philippines was actually boat. Part of it was on boats as well. So this experience, again, a lot of people were tested, 375,000, 41,000 people detected with TB. The percentage of people with TB having access to rapid molecular tests dramatically improved in these places. And we have summarized those results. 5 of the 9 countries have wider scale-up plan using Global Fund resources. The others are still considering it. There is a practical guide training package, There are also recommended operational research questions. There is a costing tool also, and there are case studies and webinars from this initiative. All of them are on the Stop TB website. There is a web page within the iNTP dedicated to TrueNat. It says TrueNat training modules here, you can see, and the modules have quite detailed and quite practical information on how to implement TrueNat in a high burden country TB programmatic setting. I encourage all of you to access those tools. Now, coming to the testing for TB infection. There are WHO guidelines for providing TB preventive treatment to various categories of people. A big chunk of that is contacts. And amongst the contacts, the guidance is that if the contacts are below 5 years of age, young children, because of the high risk, you can just initiate all of them on TPT after screening out active TB. However, when it comes to the group of contacts which are above 5 years, that risk is not so high as the under 5 children. So there, the recommendation of WHO is if the test is available for TB infection after ruling out active TB disease, you can better focus the TPT on those who are latently infected or positive for the test. For that, we provided the IGRA tests that were available through GDF catalog. Remember that these IGRA tests are the blood tests. We had a plan to make available the Kaya Reach quantiferon test, which is actually a test with a similar technology, but the testing of the blood samples can happen in the periphery. However, when we started the project, the commercialization of this Kaya Reach technology got stalled. So we had no option, but we had to switch back to the traditional IGRA blood test. These are tests that have to be performed in a specialized laboratory. So it requires specimen transportation. So the uptake of those tests we realized was low. Only 3 countries opted for it, and it was not possible to scale up because of several limitations we saw. So with that experience, we are now working on what is the alternative. And you will soon hear, actually, WHO has recommended other tests, which are also based on a similar IGRA principle, but not blood tests and not complicated. So it can be done in the periphery, just like the old traditional Montus test. It's a skin test, but more accurate. And the developers of this technology are also working on digital technology to read those skin tests, because you have to revisit the patient to read it. And if there is digital technology, that can be a simple process. So we are currently trying to see if those skin tests can be included in this project or in future. The challenge is that there are 3 products. They are not yet WHO pre-qualified. So we are expecting that SciTB, which is one of the products actually manufactured in India by Serum Institute, it's very close to getting a pre-qualification. And hopefully towards the end of, or let's say 3rd or 4th quarter of this year, this should be available through the GDF catalog. So this is something that we are eagerly waiting for. And once this happens, then it is possible to also scale up in the periphery the TB infection testing, which has not happened globally so far. So there were other things on digital adherence technology as well as TB preventive treatment, but I will not try to focus on those. The focus of this was on diagnostics. So in conclusion, new technologies, especially those that can be used closer to where people live and where they seek care, are critical to finding and treating TB earlier. This we experienced through the project. We also know that this will not happen by default. By default channel, if you introduce a new product, a new tool, it will very likely the first access will be provided to people who are better off in terms of their access to health facilities. So how can we provide it in a way that the most in need and underserved get it first? The project also demonstrated how ultra-portable X-ray and CAD systems and TrueNet systems can be used in remote settings to find TB among people who otherwise do not have access to TB, and very interesting models of how this can be done, different algorithms and different operational settings. And the learnings from the projects are being used by countries now to plan for wider scale up. We have put all the learnings on the website, and I encourage all of you to go through it. Thank you.
Thank you, Dr. Sahu. I think this provided a useful background that like how this project kind of was conceptualized, initiated, and now also the documentation. And we really encourage everyone to kind of go to the website and download those either the results brochure, which you can use for internal advocacy and technical specification for the scale up. But now what we will do, we have all the countries who are part of this initiative. And so maybe it will be really good to learn from and hear from them that like what was their experience and how do they see that is getting scaled up in their respective countries. So we have 9 presentations for this session, and we have time till lunch, right? So kind of 20 minutes is something which we are envisaging for each presentation, which includes 15 minutes of presentation and then 5 minutes of Q&A. So to do that effectively, I have requested our colleague from Nepal, Ms. Kalpana. She has volunteered me to kind of support on making that like we are on the time. So she will be our timekeeper, and she will have 2 sheets. So whenever there will be 5 minutes left in your presentation, she will hold a paper and kind of suggest you that like, so that like you are aware that like 5 minutes are left, and then like for the last 2 minutes also she will kind of signal that. And what I will also request all the presenters to restrict their presentation and provide more on the crux so that we have enough time for Q&A to learn from you. So let's start with that. Are there any other questions for Dr. Sahu or before beginning to the countrywide presentation? Then maybe we can wait. Okay, so let's start with it. So very first, we have the presentation from Zimbabwe, and I think that's a virtual presentation by Dr. Fungai Kavenga, and I request them to kind of make a presentation.
All right, thank you very much. May you confirm you can see my screen?
Just wait. We are. Can you make the presentation in the full presentation mode? We are able to see the presentation, but it's not in the presentation mode.
Thank you. I've put it in presentation mode from this end.
Yeah.
So probably it will come up. All right. Thank you very much. Greetings, colleagues from Harare, Zimbabwe. It's my pleasure to present on our country experiences from implementation of the TrueNet systems in Zimbabwe. I'm making this presentation on behalf of the Zimbabwe Ministry of Health and Childcare National TB Control Program. I'm the NTP manager in Zimbabwe. So this is the outline of my presentation. I'll take you through the rollout of the systems, how we supported the rollout, the data, challenges, lessons learned, and the way forward. So as a
Just sorry to
background,
interrupt, but we are not, the slides are not moving for us. It's still showing the first slide.
okay, let me stop sharing, then reshare.
Yeah.
Please confirm you can now see my screen.
Yes, we can now see the slides. Yeah.
Okay, I was now taking you through the burden of TB in Zimbabwe. So our instance is currently sitting on 204 per 100,000 population, with males contributing about 60% of the notifications in 2022. Our HIV co-infection rate is at 50%, and death rate at 7%. So this is the structure of our TB diagnostic network. We have 188 expert machines in the network and 20 TrueNut machines.
Sorry, again, the slides are not moving for us. So can you send that presentation here and maybe, is that possible? Do you have the presentation?
Yes, I've sent it to Bobby.
Yes, sir, please present.
Okay, thank you. May you go to the third slide, please? Next slide. All right, thank you. So this is the structure of our TB diagnostic network. My apologies, I forgot to include the 20 TrueNut instruments that are in the country, but this is the structure of our 5-tier TB diagnostic network. Next slide, please. So in December 2021, we received 20 TrueNut machines through the New Tools project to strengthen access to timely TB diagnosis in the country. This was implemented through the Ministry of Health and Childcare in collaboration with the USAID IDDS project. We did a TB diagnostic network assessment back in 2020, and this informed placement of our TB diagnostic instruments in the country. So this DNA also informed placement of the 20 TrueNut machines that were added in 2021. So placement of TrueNut machines was informed by our TB National Strategic Plan, and also the 2020 laboratory network spatial analysis. We consulted widely with our stakeholders. So on your right, then shows deployment of the TrueNAT sites across the country. So the process started with stakeholder engagement. We made sure that we had policy in place, selected the slides using the methodology I highlighted earlier. We trained our healthcare workers on the ground. Then this was followed by machine installation and subsequent use in the TB diagnosis in the country. We trained a pool of super users who were meant to support users at peripheral sites. We enrolled in the proficiency testing scheme. We held quarterly data review sessions to ensure that we analyze our data and make timely decisions to close identified gaps. We also had the remote and physical mentorship to users of these instruments. Next slide, please. So this is just showing the data in terms of outputs from tests that were done on the instruments from December 2021 to August 2022, which is just showing that over the period of implementation, more and more tests were run on these platforms. Next slide. I'll now take you through the challenges we faced during implementation. Next slide. At facilities, we experienced poor internet connectivity. Some cadres could not attend virtual trainings. Then there are also challenges in reporting proficiency testing results online. Not all our facilities have power backup, so from time to time, testing is affected by power outages, and this impacted ability to recharge the instruments. Then, in terms of our cadres, we didn't have trained and competent staff to cover staff absences and ensure continuity of operations in the event that those trained cadres were not on duty. There was also a gap in quality management system awareness with the end users. There were a low number of specimens that were received due to information gap in receptive catchment areas where healthcare workers, or should I say clinicians, some clinicians were not aware of the existence of these instruments. So we had to go on a drive to train, build capacity in our healthcare workers, sensitize them about these instruments. There was also poor specimen quality that we experienced at some facilities. Next slide. Then in terms of lessons learned at facilities, we learned that backup power should be provided to charge the machines. And we're excited that we have a Solar for Health project that is making sure that all our laboratories across the country have backup power. Then, of course, providing internet connectivity and providing ancillary equipment and support. Then in terms of the users themselves, we learned that if a group of super users is actually essential to support implementation of quality practices and assist with EQA activities. Then refresher trainings are needed from time to time to ensure there's continuity of operations. Then end user in-person refresher trainings should include good laboratory practices, EQA, and quality management system sensitization. So our next steps, we'll continue supporting super users. We've included support for the TrueNut machines in our GC7 funding requests. End users are to monitor errors and conduct root cause analysis. We intend to connect all our TrueNut devices onto the Laboratory Information Management System platform to strengthen real-time reporting. We want to implement recommendations from our diagnostic network optimization exercise of 2023, and the recommendation was to purchase 23 TrueNut machines and place them to relieve 18 overutilized gene expert sites and open the TrueNuts for early infant diagnosis and viral load testing. So I can confirm, as a country, we are looking at purchasing 63 more units, and we've since, unfortunately, these are not covered under any funding mechanism for now. We do have these 63 units in our prioritized above allocation requests in our GC7, and I hope soon we'll be reprogramming our resources to cover these 63 units that we intend to add to our network. Next slide, please. I would like to acknowledge the Ministry of Health and Childcare for their support in us implementing this project. The USAID, then IDDS, the Stop TB Partnership, and Organised Diagnostics, who are our local support partner for the support they have been giving us in making sure that our instruments are up and running and functional all the time. Thank you very much. This brings me to the end of my presentation.
Thank you so much, Dr. Kavinga. I think you made a really good presentation, very crisp but to the point, and it was very clear. So maybe we can open up the floor for the question and answer. Any questions from the house? Yeah, I see there. Can you give a mic?
Thank you for the presentation. Can you tell us a little bit about the criteria that you used to place these machines? I mean, this is already a country that was implementing other tests. You got these new TrueNut machines. How did you determine where to place them? Thank you.
Were you able to listen to the question, Dr. Kavinga?
Yes, thank you. I got the question.
Yeah, sure.
Okay, thank you. I can respond. So thank you very much for that question. We did a diagnostic network assessment in 2020. So this informed us of gaps that are existing in our TB diagnostic network. We were also informed by our TB National Strategic Plan and stakeholder engagement processes. So I can say there was a clear criteria to place these TrueNut machines. So that we're intending to add more units in our network, and already in 2023, we did a TB diagnostic network optimization exercise, and this will inform placement of the additional units that we intend to add. Thank you.
Right. Thank you. I think and what I also want to add is that like this diagnostic assessment network the network assessment is really critical in general, because time to time what we have also seen that like not just about only the TB network, but in general there is a larger health system strengthening approaches are also happening. So we really want to see, and especially after the COVID, there are many instruments and the diagnostic platforms have been infused throughout the countries. I'm sure like that has been the case for the other countries as well. So it is always good to see how can we optimize the other platforms before just procurement. I have the following question. Let's say with this, what the plans look great, Dr. Kavinga, but is it something like with this global fund scale and the machines, number of machines, will we will able to kind of provide the upfront molecular test for all presumptive TB cases using this, or we will require more?
Thank you very much for that question. I think according to our TB diagnostic network optimization, 63 more units probably is the minimum. But I guess as we are intending to review our program, identifying gaps, and also trying to catch up with our UN high-level meeting targets, I see us probably adjusting our expanding our TB diagnostic network further as we're likely to have more presumptive patients. Therefore, it may mean we may need to expand our TB diagnostic network. Thank you.
Right. So I see a question here. And I also just want to add to this that, like, because in future we will also have the active case finding rounds and everything. So when you actually try to see what are the number of machine needed, please factor in those things.
Yeah, thank you very much, Dr. Kavinga, for this really enlightening presentation. Yeah, you have 183 gene expert, 20 true nuts, and you plan to buy more 63 true nuts. I just want to help me. Why more 63 true nuts and not gene expert, not lamp? Or what is the mix here? Depending on your DNO and your experience. Thank you.
Yeah, maybe we can also add one more question and then you can respond.
Thank you. Thank you. And Kavinga, thank you. This is Dr. Raymond from Uganda. I just a follow on to Professor's question. In terms of the TrueNut machines that you are looking at, are they going to be, again, 2 module? Are they going to be 4 module? And the optimization that you talk about, my understanding, and I beg to be corrected, usually it's an intention that you tend to pull together so that you can be able to optimize the machine that you have there. But in Zimbabwe, is that the recommendation to have a bigger throughput machine so that you can be able to optimize it, or pull these machines together and be optimizing them, or your intention is actually to decentralize more deeper down into the at the almost community level? Thank you.
Dr. Kavinga, you may respond to the
Thank you, Mr. Chair. I think I'll first respond to Prof. Moses. So really our decision on which instruments we need to procure to expand our network is based on our experiences on using the Gene Experts platform and the TrueNut platform in our network. And I think we also engaged our stakeholders on how we can move forward. We have challenges with power supply in our country. We have had to reach communities. So the TrueNut machine gives us that opportunity to deploy it further down in our communities. It comes with its advantages, and this is the reason why the country has gone to decide to take TrueNut. There are also issues of after sales support that we get from our partners, and I think with TrueNut, the country is happy with the support that comes with it. TrueNut is also cheaper in terms of reagents, in terms of costs per test. TB lamp is at the moment is not part of our diagnostic network. We haven't decided to use it. I don't think we'll be adding it to our network at the moment. Then thank you, Dr. Raymond. So in terms of our the direction we are taking, my apologies, I forgot to mention that we did a DNO and a spatial analysis in 2023. So we're looking at expanding the number of units and also moving some units around depending with utilization of those units and the number of presumptive TB patients we envision to access testing. So it's a mixture of factors that made us recommend to expand the number of units. But we're also moving instruments depending with their capacity. So we're looking at getting both the 2-module and 4-module TrueNut units. And according to our spatial analysis and DNO, these will be placed at already predetermined and selected sites, depending with the disease burden and population to be served. Thank you.
Thank you so much. And maybe this will be the last question.
Thanks, Dr. Shah. There is a comment from Dr. Suvanan Sahu on Zoom.
Okay.
So Dr. Sahu has said Zimbabwe has done very well in depending on molecular diagnostics rather than microscopy. WHO data shows 100% of people diagnosed with TB are tested with rapid diagnostics at time of diagnosis. Thank you, Dr. Sahu, for this comment.
Oh. Yeah. Maybe the last question now. Yeah.
Thank you very much, Dr. Karenga. My name is Mgaza. Mine is just an an advice. I hear you were mentioning challenges around some sites that were not able to run due to power challenges. We do have for mobile some solar generators that can help you to recharge the units using solar energy. You can contact me for more information on that. Thank you very much once again.
Yeah, no, I think that is useful, and maybe this kind of combination is really required. And we have seen how solar system can kind of be used. So I think thank you so much once again to Dr. Karenga for remaining virtually present here. It was immensely helpful. Maybe we'll move to the next presentation from Kenya, and I'll request Mr. Stefan to kind of come here and make the presentation. So you can see the Kalpana and she will kind of give you.
Good morning, everyone. My name is Stephen, CEO Step Lab Technical Services, a partner with Mobile in Kenyan market. I know we have a slide, so as you put up the slides, tips, it's good to know that for the strength of this project, you need to have strong partners in country to support you, especially those who are from the NTB programs and also from the government side, because at the end of the day, whereby partnership is the biggest strength we can always rely on. Thank you very much. At least 2 years down the line, we have been able to start the implementation of TrueNut. We have been able to start implementation of TrueNut project within the Kenyan facilities with the help of the government of Kenya itself, USAID, Stop Partnership, TB, and TB Track, and also CHS. Basically, our presentation will put the steps we had to put down, and then the TB diagnostics, the criteria to select sites, capacity assessment, and then also TrueNut training in country for the users, and also how to implement the project. And I believe that colleagues, the most important part of the most important part of our presentation is as partners and as Mobile, what are the challenges we have undergone to implement this project? Basically, there are several implementation steps which we need to look at. In 2021, there were meetings which were conducted between the ministry and several partners within the country to make sure that implementation takes place with the support from USAID and CHS. Kenya is largely a populated country with 52 million population, and is one of the countries whereby is in the list of high burden countries. So we had to map the country, putting in mind that we have 210 gene experts. We have all other units, TB lab, 26 of them. We have the digital X-rays. We have the IGRA testing methodology with 2 sites. We have 2,670 microscopic sites whereby they are used for testing. But Mobile came very anti on this because of the advantages Mobile TrueNut comes with. 1 is accessibility, 2 is the cost, 3 is a unit which you can place in communities without high cost, and 3 is the easy to use. So the first thing is to look at selection criteria. And what we did is that we did a baseline based on the 211 gene experts in the country, look at the distance whereby they are placed, and how we can minimize that distance whereby we are sending samples. And those facilities whereby they are using also microscopic smears, we had to take advantage of it. And then also, we are trying to look on waste management, and I think these are discussion I need to have with Mobile because of the nature of our tests, the electronic waste management and disposal. We need to start thinking about it because I can imagine within the next 5 years, we have done almost 30, 40 to 100 million tests. How do we deal with the waste management from these units? It's quite critical. So we looked at the capacity of the labs, whereby we needed to see whether there is accessibility of data, there is accessibility of power, there is accessibility of more importantly, the equipment used. And we came up with the assessment laboratory capacity infrastructure, QMS, commodity management system, data reporting, LIMS, and also to support the infrastructure. And we fairly looked at the remote labs within the counties. Kenya has a devolution system whereby we have the national government and 47 counties. Those 47 counties manage quite a number of health facilities at the lower level. So we started with 38 units in the country. That was last year. We were able to implement the 38 units in the 38 sites. And early this year, we have increase that number through the support of Stop Partnership TB, whereby we have just concluded the installation of another 40 units. So in total, we have right now 78 units, and we have another 40 units which are coming in. We intend to start implementing by the end of July. So in total, we'll be having at least 118 units in the country, whereby the system is not working. All right. Oops. So the first thing you need to do is that first, as a local partner or the NTB programs, you need to do is first to identify the users of this training, to sensitize the NTP on the advantages and how to implement the project. So we held several workshops in support with CHS across the country, with whereby we had put the country into clusters with the support from Kenya Red Cross, Kemri, and also Liverpool. And in total, we were able to train 47 users for the first phase of the equipment. Then we had a second training whereby we pulled together laboratory teams, coordinators from the 47 first sites, whereby they were supposed to condition facility mapping of the optimal demand and redesigning sample network including the first training, actual training or actual testing in the lab. And then the second level is for the super users. The super users become very handy for the implementation of this project, because they become your key contacts, people within, and there's a super user is able to help his colleagues within the country to make sure that they interact and make sure that get the mobile direct. So it is very critical when you are implementing this to make sure that at least you identify your super users very well, because they are the main key guys. They are laboratory staff within the government, and they have a super role. So training for them become very intense, and we are glad in Kenya we have been, well, the first round we were able to train for 33 super users for both application, and as we speak right now, we are training super users. Those are biomedical engineers, to make sure that they sort out small issues within the locality where the equipment are, with the support of the local partner. Then we had another training whereby we had to put the entire country into 3 clusters, whereby these are the end users. The end users are the teams whereby you install the equipment. exactly in that lab. So you make sure that once you identify your sites, you need to identify the technologies, laboratory technology who will definitely be your end user. Basically, installation of TrueNAT was barely conducted by us, Step Lab Technical Services Limited. And I want to say that if you're a partner, you need to be prepared for this. It's not easy because at the end of the day, you are responsible to make sure that all the equipments are installed, trained, and they are working. There are challenges which you'll see in a few minutes' time, whereby you also need to do the QA. These are some of the strengths whereby working with the end user. And one thing, end users, we have put them into a network whereby at least they can report to us within 24 hours in case of anything, and we are able to respond within 24 hours. So one thing we have managed to give Gene Expert run of their money is turnaround time of how you manage your system, and you don't allow your system to be down at any given time. The role of super users is purely supervision and to look at the to make sure that they visit the other teams on the ground, and if there is any case, if there is any issue, they work on it. As we speak right now, we have already implemented 78 units, and we are implementing more. There are definitely challenges, and you need to find solution as quickly as possible. The issue of data capture in the register versus TrueNAT, you have to come to have very clear documentation of the correct method to make sure that those data are corrected. You need to have to flash protocols, not consistent done with the SOPs. Then you need to rely a lot on the super users and also do a lot of refresh training on them. There is the issue of power in most of the countries. There is the issue of network in most of the countries. The solution for power is solar. The issue of network, quite a number of countries, you don't have optic cables. You must rely on mostly on the mobile technology teams who are on the ground, or mobile companies. For Kenya, we are lucky to have a very strong network from Safaricom and Airtel. So you just get the normal local SIM cards to be used with the system, and you'll be able to know exactly what is happening with the system from where it is at a local time. There are lesson we have learned. The issue of continuous training, the issue of making sure online data submission is, we are lucky in Kenya, we have been able to be supported by the USAID through a company called Smart Stop of support of the data from the equipment to the end user. But more, as I conclude, the way forward, and I think this is more critical for all of us, yes, you can implement all the equipments, but how do we scale up testing in the country? And I want to suggest that for us, we are now planning to make sure that we move from the diagnostic part to the clinician part. And we are planning to have at least a training for the clinicians and also doctors who are the first contact of the patient when they come to the clinic, and make sure that the doctors are aware that this tool is available in the country, and they can request for testing of TB, use it TrueNAT. Because you find most of the clinicians globally, when they request for TB testing, you'll find them writing on their prescription, Gene Expert. Gene Expert is not is just one of the tools. So it's good to sensitize the doctors so that we can upscale the use of reagents within the country. And this is, I find it very key if we want to sustain this program. And I will request Mobile, and I know we have a meeting with the teams, that we need to get proper information on how to approach the doctors, how to approach the clinicians, and give them the advantage of these two. These are tools whereby you can put it anywhere in the country, easy to use, and make sure that at least we attain the United Nations goal of ending TB by 2030. And to end TB by 2030, for those who are here, is to make sure that we test everybody. And for me, we are trying to encourage the government of Kenya and the teams on the ground, if we can at least test TB to each and every walk-in patient. That will be fantastic to make sure that we deal with the issue of ending TB and make sure that we sustain the goal and make sure that we also scale up the testing. Thank you very much. I want to acknowledge all these partners who we have worked with, and it's good for the implementers. Please make sure that at least you have a good support of a company within the country to make sure that you support the solution for IT. Thank you very much. Yes.
What does the government plan? By which year would you replace microscopy completely with molecular testing? Is there any plan for that?
Basically, because of the nature of the distance and structure of the government, for me, I will not encourage replacement of microscopy, because at the end of the day, it's a long tool which has been existing. And you'll find you cannot reach all the sites in the country. So it is also helping us whereby we still need to have the microscopy testing in the lower part of the country, whereby if there are any issues, then they can be scaled up. Every tool within the health sector has its own role. And I will definitely, we have encouraged to make sure that the microscopy still exists, but we move with the new technologies, because at the end of the day, it is also saving life. So what we are encouraging the government is that to make sure that at least we scale up TrueNat to a tune whereby we are at par with GeneXpert. And I just want to say Kenya has done very well. Within 2 years, by the end of this year, we'll be at 50-50 with GeneXpert. And with the challenges we have seen on the market with GeneXpert, I can assure you that the request of TrueNat will be the golden tool for the future, because it's a tool whereby you can even implement where there is no power. It's a tool whereby you can implement where there is no fiber optic cable. But I will still encourage, for the sake of humanity, we still have the microscopy testing at any level so that it can complement whatever we are not able to get. Sometimes you never know with technologies what happens. The systems are down on the river, and you'll never, you never know when the patient will come in. So you still need a tool there. But let's make let's make sure that TrueNat become the golden tool, but also the other tool can exist to be the backup. Don't allow TrueNat to be the backup. Let TrueNat be the main line of power to diagnose, then the others to be the backup.
Yeah. No, I think her question was misunderstood. You can never replace your microscopy, because you will always need it for as a follow-on or a test to know how the patient is progressing. What she meant was, can we replace your microscopy with rapid molecular test for diagnosis of TB? Because you will not miss patients. You have huge sensitivity, specificity, so you will get additional patients with the same test. You do a sputum, you will miss some patients. Use sputum for a follow-on, use microscopy for a follow-on test. So that's what most countries are actually doing. So replace mere microscopy as a diagnostic tool for diagnosing patients of TB. Use smear microscopy for follow-on test. Test at 2 months for smear conversion. test at month 6 to see whether the patient has been cured or not. So that's what the general recommendation is. Thank you.
Thank you. That's why I said let the microscopy be the backup, whereby you can follow up the patient and whatever. But let's make sure that at least TrueNAT become the golden test of TB in the country. Yes.
One question here. Yeah. Okay. Actually, two questions rolled into one.
Thank you.
The first thing is, in terms of, you said that you had rolled out about 40 installations right across various sites. What was the time frame that you took to accomplish this feat of rolling out 40 installations? That's one. Number two is, how do you ensure the hand-holding process for the new end users who are very tentative when they use newer technologies?
Thank you very much. I want to say, first and foremost, as a partner, you need to put up a team and make sure that that team is trained by Bombayo. We have 2 application specialists, and we have 2 biomedical engineers. There are tools you need to facilitate those young people with. They need to have the correct tools, they need to have correct training, and they need to have the correct tools of work. That is the vehicles, they can move across the country. And the most interesting, it was for us on the implementation of the 40 units, which we did in a record time of 2 weeks across the country. 2 weeks, we installed 40 units, they're up and running, they are working. And it's squarely because of highly trained biomedical engineer and highly trained application specialist. So those 2 cadres are very critical in implementation of this, and they complement each other. When we are doing the installation for the first 38 units, what we did is that we combined a biomedical engineer and application specialist to go to one site. Why? It's transfer of knowledge. The application specialist is not a trained engineer, but he can see how to install the unit. And a biomedical engineer is not an application specialist, but he can be able to train on the use of the equipment. So the second round we did is that each and every individual was alone on its own on site, do the installation, train, do the QA, collaborate with our lead team in the office and the lead team on mobile in case of anything, and it's real time. And we were able to install 40 units within 2 weeks. We want to see whether we can break the record when the other 40 comes. We saw them in a week's time. Because the network is a matter of how do you position your logistic. Logistics is very key. You make sure that the equipments have already been sent to the sites, they are there. You release the team, you are on control of the team, and make sure that the teams are able to do that. The other thing which is very critical is that with the end users, they really help you on the ground because you have already trained the users, that's the end users. So the end users are trained prior installation. Don't go and train end user during installation. So you need to map up resources with the partners in the country to make sure that the end users are trained prior installation in a cluster, like a workshop like this, and it works very well. So when that, during installation, when the engineer or the application specialist gone to the site, this is somebody you are not introducing him new theory. He already has an idea of what is, so it becomes practical and very fast. What was your next question? The second question. That's why the first and the second and the third training is very important, because you need to start sensitizing the users on new technology and why. And what we normally do is that with the help of Stop Partnership TB and CHS, we put them together in clusters and do training. As I said, as we speak right now, when we are here, one of my biomedical engineer and one of the application specialists, they are already in Nakuru preparing for the next 4 sites. The equipment have not, the order has not been confirmed, but we know it will be confirmed. The equipment are not in the country, but we start early enough with the support of CHS and NTB to make sure that we start sensitizing those end users or not. So the best thing is that start early training when you know exactly the orders are coming, so that when you go out for installation, it's a matter of installing the equipment and running real samples. But also during training, what we normally do is that, and Yvonne is here, we normally make sure that during the training, there is real testing of TB, because we normally do the training in one of the towns called Nakuru, and next to the training center, we have the Nakuru PGH, whereby is one of the TB testing site. So in the afternoon, they are actually in the real lab, and they can see what exactly they expect. And also, easiest molecular testing I've ever gone through. I started my career as a biomedical engineer with very long testing of nucleosense from bioMérieux, which was a long, tedious molecular testing. Things have changed.
Thank you. Mine is, it's an add-on. As a media person, we have to simplify the language. People will ask me, why are we now going to the TrueNut instead of using the gene expert? I will explain that the gene expert can detect mutations of the RIMPA, what is it?
Rifampicin.
Yes. And now with the TrueNut, it's an added advantage. It can detect mutations of rifampicin and isoniazide. So it's an A-star equipment from the A that we were working with. I just try to make it a simpler story.
Yeah, you need to make it as simple as that. And I want to say that from biomedical scientific view, TrueNut is a standard God tool, because at the end of the day, after your extraction, you remain with that sample, you remain with the elute, whereby you can keep that elute at -86 for long as you want to keep that sample. And we still have the advantages of COVID. I know quite a number of people don't think COVID had advantages. COVID had advantages in most of the country, whereby serious infrastructure on some of these units like -86 and the rest are already in place. Now COVID is over. Take advantage of COVID menace to make sure that that structure which was built by COVID is used to the TB. Am I making sense? Okay. Oh, there are other two.
Okay, thank you very much. My question, I have just 2 quick questions. The first one is the 40 that you added on the 38 and the 40 expecting. Is there a particular funder that is procuring them for Kenya? The 80. Then my second quick question is there still an opportunity for the country to procure more gene expert machines, or now they have put a hold on procuring gene expert machines and they're scaling up the TrueNut machine?
Thank you. I'll start with the last one. As a businessman, I will not allow gene experts anymore. We'll make sure that we have mobile. 2 is that I've said where you come from, you need to take advantage of the funding which came through COVID. The 80 units and the 80 units which are coming in, the 40 and the 40, what happened is that we had a lot of money which had been put by Global Fund, TB Alliance, and other partners in the country. And when COVID went down, we reallocated that money to TB. And that is the money being used to procure the extra equipment and extra reagents. The same time, we also have a very strong relationship with the Global Fund in the country, whereby it has been supporting TB program for a while. So they have scaled up the funding, and we know very well they are putting money to buy the reagents for this equipment. So let's be selfish. Let's make a TrueNut the king. Don't allow your teams to continue suffering with the inexperience and problems of gene expert. I'm sorry, but that is the position.
Yeah, thank you for accommodating my last question. This is more for the user level. Because it's under iNTP, the project hired medtechs to to operate the machines and all. If we're talking about expanding, HR will be a big issue. Now, one question is, can we comfortably allow non-medtechs to operate the machine? I'm speaking of TrueNAT. Or we really have to have as the minimum level of credential medtech, no less, because it would requires pipetting skills and all that, biosafety, etc. So I would like to throw back the question to any of the speakers.
I will just throw a question back to you. Will you allow yourself to be driven by somebody who doesn't have a driving license? The answer is no. So we will not allow anybody to install or operate TrueNAT who is not trained. It's as simple as that. Let's use simple language here.
The reason why I asked this is before when the microscopy was used, they actually asked community workers to do the smears. And then, of course, it's the medtech who would read using the microscope. But now we have to firm up with that standard. Are we allowing just medtech to run the machine, or we will allow also trained community workers to run the machine? So that is something, because we are moving towards universal healthcare, and minimum licensing would require minimum HR requirements. Thank you.
Thank you very much. I will still go back. When we were using microscopy and allowing community health workers they had to go simple testing within the lab. But here we are dealing with molecular diagnostic, which require high skilled. Basically, as I said, you can't allow somebody who doesn't have a driving license because he knows how to ride a bike to drive you. So at the end of the day, I will still insist proper trained personnel to handle this. And let's be honest with each other. We are dealing with a deadly disease. If there is any wrong diagnosis, wrong reporting, you are scaling up TB within your country. So I will request kindly make sure that the teams handling the molecular testing are trained. And I believe it's the interest of every government to make sure that their staffs are trained. But let's not assume that everybody can handle this. Let's have a basic training qualification for all the people handling this. Two, it is very costly. When you can imagine the equipment is 1,000 miles out of town and is messed up by somebody who is not trained, you require an engineer to go there. You require to get in touch with mobile. It is. So let's make sure that the basic training requirements for the users and the biomedical engineers in the country, it's real. It's not virtual. It's real.
No, the confusion is arising because MedTech, we are assuming university certified. I mean, they have academic qualification. So what he is trying to say is training. So there is a difference between academic qualification and training. So what is recommended is, since you are handling biological specimens, that's one. You should at least have knowledge of infection control and have some basic idea of healthcare, space, life sciences, etc. Some basic knowledge. You may not be a trained lab technician or something like that. And that's the advantage of closed systems, because you are making things very simpler. So you are making it more friendly to use. But still, the recommendation is that any healthcare worker who undergoes a basic training and knows about how to handle biological specimens can do that. So that's why he's stressing again and again on training. I'm trying to separate out academic qualification versus training. And in most setups, even in our country, under National Health Mission, where you don't get trained anesthetists, academically qualified anesthetists in the rural setup, they give us 6 months training to a general doctor and use him as an anesthetist. So times are changing now. So if you want to go to periphery, maybe you have to use healthcare workers, train them well. They may not be, because it's difficult to get everywhere you academically qualified people in all settings. You get them in urban areas, you don't get them in rural areas. Hope that clarifies.
Thank you very much. If there are more questions, we can direct in the evening. From Ethiopia, just one?
No.
Okay.
We
Thank
can have in this side conversation, maybe. So what we will do now, and like he's my own colleague, so I can request him to enter. So let's see what we do. I will go for the next presentation from Philippines. I request Dr. Samantha to present. And so what we intend is after this presentation, we will have a short tea break. So, and then so that we are on time overall. Thank you.
Oh, it's really high. Good morning, everyone. I want to teach you a little something before we leave, a little language lesson. Can you all say in Cebu, where I live, we say maayong buntag. Can you say that? Maayong buntag. That means good morning. But in the island, which I found out when I moved there, there's a totally different language called Bantayanon. And in Bantayan, we say maayong aga. Maayong aga. Okay, good morning, everyone. I'm Dr. Samantha Tinsay. I am the Municipal Health Officer of Bantayan, Cebu. I'm just waiting for my slides to show up. So a little bit of background about me. I grew up in the US in Southern California. And then I did my training in public health at the University of California, Irvine. And then I moved back to the Philippines on a whim to do medical school there at Cebu Doctors University. And I ended up staying there. Yeah, I ended up staying there. I was only supposed to stay in the island for 6 months. I told the mayor, I'm only there for 6 months and then I'm going to do something else, but it's almost 3 years and I'm still there. I'll tell you a little bit of why, and we'll go through a journey through the island. Okay, so my presentation is called Reaching the Unreachable, Finding Missing TB Cases in Bantayan Island, Cebu, Philippines. Maayong aga sa aton tanan. So a little bit of a geography lesson. Bantayan is located in Visayas, which is in the middle of the country of the Philippines. And Bantayan Island itself is located in the northernmost portion of Cebu. So as you see, from Cebu City, I have to take a 4-hour ride, either in a bus or in a car to get to the port of Hagnaya. And then I take another 1-hour ferry to get to my home in Bantayan. So coming here, I took all modes of transportation, a ferry, a taxi, a car, a bus, an airplane. I don't know what else is missing. Maybe a helicopter or something like that. A train. Okay, a bicycle. Maybe later. So this is where I am right now. The reason why I stay there, it's because it's a tourist hotspot. It's a beautiful place. I'm a beach person. Growing up in Rojas City in the Philippines, also in Southern California, I love to surf. I love to go to the beach. So this is why I fell in love with the place, because of the ocean. These are real pictures of the place. So if you want to come there, you are more than welcome. Just let me know. So this is one of the modes of transportation. So last week, because right now it's a little bit of background, we were an iNTP pilot in September 2022. And so USAID donated the tools to the Department of Health in the Philippines. And I was able to get the ultra portable X-ray. And thank you, Molbayo and Gets Healthcare, for letting us the TrueNAT also. So this is we call it a pump boat. So this is what we use to bring services to other islets in Bantayan. So Bantayan is composed of 25 barangays or townships, 5 of which are islets. So it's not just one island, it's an archipelago. So there's other smaller islets. So this one, this was my Instagram story. Sorry, I can't really draw that well. So we're going from Bantayan, the mainland, to Mambacayao Dako, which is actually located closer to a different province of Negros than to Cebu. So this particular island is served because of certain misconceptions about the people who live there. First of all, one was safety. There was a threat of possible a terrorist group that stays there. And then they were telling me, oh, they pretend like they're fisher folk, but they're not. So don't do medical missions there because you might get murdered or kidnapped. But anyway, it's been 2 years and nothing has happened. They just give us fresh seafood every time we come there. So, yeah. So, I don't know where. Okay. So this is an example because in my last presentation at the Stop TB Partnership in Manila, people were asking me, why do we have to go with a high tide? So now here I have more visual aids for us. So in Bantayan, to go to the other islets, we need to go whenever there is a high tide. Because if it is a low tide, the boat cannot traverse through the ocean, or sometimes we have to walk. Or sometimes we have to take a smaller boat to get to the bigger boat. And that's what we call a bote-bote, this one. This one especially is very unstable. One wrong move, you can fall down. And I just found out from our first active case finding that half of my staff don't know how to swim. I don't know, and they all live in an island. So anyway, if the boat can't traverse through, we have to walk across. So you gotta be willing to get your feet wet, literally and figuratively. Okay. So this is another scenario where we went in the high tide. And this was at 1 a.m. And I felt really bad because we had a new doctor starting with us on that day. And I told her, sorry, Day, you have to show up at 12 midnight at the port. And she did. I'm glad she's still with us. She hasn't quit just yet. Okay, so our first iNTP pilot was unfortunately during typhoon season. But when USAID tells you we're going to let you borrow these new tools, you just run for it because we never know when this is going to land in our island. So this was our first iNTP case finding in a place called Bantige. So this is the USAID FHI 360 team. So we have the full package, as we say. We have the Fujifilm X-Air Ultra Portable X-ray, the CAD4TB AI by Delft, and then the MolBio TrueNat machine. So again, these are our new tools that we used. So let me just go over the data really quick, just to highlight how important it is to have technology in our fingertips. So unfortunately, in 2021, we had a very dismal case finding. We only X-rayed 180 people. That's because people were hiding from COVID. And as you know, the Philippines had one of the longest lockdowns in the world. And then, thank God, in 2022, FHI 360 came to us in September 2022, which was probably the worst weather we had in a while, and told us we need to do active case finding. And as you can see here, we did 732 traditional X-rays, and we do this with our partner diagnostic centers, so the people can go there for free using our social insurance, and then the local government unit is the one that pays the labs. So we have public-private partnerships in place also. So with Ultra Portable X-Air, we were able to screen 1,774. And this was just in the span of September through early October 2022. In 1 month and a half, we were able to screen way more than the traditional. And in 2023, we were able to get back the new tools in November. So since we were just using traditional X-ray from January until October 31, 2023, our case finding wasn't as high. But then you can see here with the ultra portable, we were able to screen 1,000 patients in 2 months. And then now, as of May 10th, 2024, I thank my program manager for always keeping a good tracking of our data. So we were able to screen 369 with the traditional X-ray. And again, this is through our partner diagnostic centers and also our mobile vans. And then, but with the ultra portable, we were able to screen 2,784, driving up our case finding. Where am I supposed to click? Okay, there, sorry. So our target from the Department of Health in the Philippines for our TB presumptive was only 1,544, and we've already surpassed that using the AI and the technology in our fingertips. So this is our algorithm that we use. So we do a one-stop shop pretty much. So we do TB and HIV screening all in one go. So we check using first the ultra portable X-ray. And then if we see any normal findings, we tell them to follow up after a year. If we see something else like pneumothorax or something else, we refer them to a pulmonologist. And then if we see that it lights up as tuberculosis on the chest X-ray, then we proceed with either the gene expert or the TrueNat. So the TrueNat, currently we're using it when we go to our field work. Because in certain areas, like the islets I showed you, we can't bring a gene expert machine there. So we bring the TrueNat, which is very accessible and mobile with us. And then so we check for if it's DSTB or DRTB, and we give the appropriate treatment. And then all our TB patients, we also screen for HIV. So currently our rate is 3% of our total tuberculosis patients also have HIV. Okay, so for TB case detection rate, it's actually, we're doing pretty well because our local government unit does not rely just on the medication from the Department of Health and from the province. We also procure our own medication for our buffer stock because we already know our high caseload. So we already order medications on our own. So we don't rely on just the national government. So as you see here, in 2022, we had a case detection rate of 96%. 2023, it went a little bit down because we didn't have the tools in place until late October. And then in just as of last week, we're already at 52% for our case detection rate, and our Department of Health target is 386. It's not even halfway through the year, and we're already making strides in our targets. So as again, the technology speaks for itself. Okay, so data is a little bit boring, so I have more pictures because we're visual creatures, right? So what we do, since we're going out to the people, these people before I came, they were not used to seeing doctors. I'm a little bit of an adventurous person. I like to talk to people, get the community engaged. And so now we're building rapport and trust with the community because we are the ones going to them and by providing services. So we don't just do TB screening, HIV screening, we also bundle these services up. So we also have routine childhood vaccination. We have free dental services. This dentist is also a council member. He's a politician and he also joined us. So that speaks a lot in how the community wants to be involved. We also do family planning services, breast and cervical cancer screening, as well as free medications in our pharmacy. So we have a FDA approved pharmacy and we bring medicines also to the people. And these are all for free. They have no charge whatsoever. So we also leverage technology. I don't know if you can see this, but this is my staff putting up a Starlink on top of a basketball court. So we also use technology such as, since we have very poor internet in the Philippines, if you've been there, you know, the internet is horrible. So right now we were able to procure Starlink. And so we're using it to also register patients in our social insurance and also register them in our electronic health records. So as of now, we are the only local government unit in the Visayas region using electronic health records, because we want to be able to track our patients using technology, not just paper-based anymore, because we want to keep historical data. So when I came into Bantayan, there was no data to be had. Everything was on pen and paper. So now we can see, we can track these families and follow up with them because now they are in our system. So as you see here, we're in the middle of nowhere, but we have laptops. And this is me doing consultations of patients using the EMR. So we can also track not just medications, how much medicine we're using or billing or need to procure. We can also see their health status, how many times they do consultations with us, and which families we should target more for nutrition support, which we are also doing with our lifestyle medicine program. So we are the only LGU, again, in the Philippines doing lifestyle medicine. So we do free group classes, free exercise classes, nutrition classes for our community. And my mom also does chair Zumba. Hi, Mom, where are you? She does chair Zumba for the senior citizens who are disabled and can't stand up anymore. So this one, again, shows you how dangerous it is when we have to look for the high tide. So this is us. This is my fault because I took so long consulting someone. So now it's already high tide and we had to go across the island carrying 9 million pesos of equipment. Thank God nothing broke because we don't own any of this. Lugging it across the island to search for the high tide. So this was during our pilot. Yeah, so we're carrying the ultra portable there. Yeah, so because we took so long, it was already like we had to go what we call overseas. So we had to go in the open ocean and now brave the horrible weather during typhoon season. We're still smiling here. Yeah, because we were still able to take pictures, but after like 15 minutes. So a journey that was supposed to take 40 minutes took us 3.5 hours. And the mayor was already texting me like, are you alive? Are you okay? Where are you guys? The Coast Guard was already looking for us. That's how it is. But when USAID says, let's do this, you got to do it. Because I don't know when they're going to come back. So because of these tools, the numbers speak for itself. You can see that the TB case notification rate in 2022 shot up to 517. That's because we were finding TB cases that were hidden in the woodworks during the COVID-19 pandemic. And then in 2023, we were still above the national baseline of 378.78 with a 388.57 TB case notification rate. And currently, since last week, our TB case notification rate is 229.57. And our current just for Bantayan alone. But the whole island has around 160 because we're composed of 3 component municipalities. Okay. So I just want to talk a little bit more about the people behind my team because this is not a one-woman show. It takes a team of 60 to 100 people to get this work out in the islands. So I just wanted to dedicate this talk. I don't know if you've seen this talk, but I don't care. I'm going to dedicate it again to her. This one next to me, she was our med tech. I say was because she passed away, unfortunately, in 2023. So she was our med tech that decided that even though she wasn't feeling well, she was still gonna go and do case finding with us because she believed in the cause. And she was the one who decided to do HIV testing also because she thought that it's good to bundle services like this because people in the islands are scared of doctors. They go to faith healers where they drink tonics and plants and all of that, which I don't disregard because that is the culture there. But now we are using technology to educate people and to bring this disease to light, because before people were just dying of TB. I saw patients as young as 6 years old die from tuberculosis. And now, because of these technologies, because of these forums, this platform, we are able to screen and treat more and save lives. We also serve the disenfranchised. We go inside the jails. We are one of the few municipalities in the Philippines that actually partners with the jails and goes there regularly. I go there every quarter to do regular checkups of the inmates, because I believe that people shouldn't be judged for their mistakes. They should still receive the same health services as everyone else. And then this case is a case of POTS disease, where we had to debride in the house because she couldn't go to the clinic. So these tools are good, not just for people who are there. It's also good for people who can't access services the normal way. Because in the Philippines, if you are a prisoner, you need a court order to even get a blood test or an x-ray. So we go in the jails. I'm not scared. They're really good people, actually. Some of them cook for us. Okay, so for our TB treatment success rate, since we do procure our own medication, our TB treatment success rate is always above 95%. So currently, last year was 98%, and currently we have treated 110 out of 113. This year alone, this was last week's data, with a TB treatment success rate of 97%. So it's important not only to use the tools, but to also purchase the medication to treat the diseased. So I just end my talk with the reason why we do this work. It's not because of numbers. It's not because of accomplishments. It's because of the people. You have to remember, we are dealing with lives here. It's nice to have a good national TB program, but it's also good when you're able to see your patient live a normal life. So this is a case of Joseph. Joseph was 23 years old when we saw him. The only reason I was able to see him at his house was because his barangay health worker or community health worker was very concerned that he was bedridden for almost a year. A 23-year-old suddenly bedridden, why? So everyone in the community thought he had HIV, and they were trying to stay away from him. So when the barangay health worker reached out to us on social media and was like, hey, we need to see this patient, no hesitations. We went ahead, saw him. He was covered in sores. He was only like 28 kilos when we saw him. So I was able to bring my med tech, the same one that passed away. She was able to take bloods and get this patient checked. We did the sputum test. Turns out he had pulmonary tuberculosis. We got them admitted. Getting him admitted was another journey because we had to fight the family. The family was like, we're not going back to the hospital. He almost died there. So that is also the conception that we're trying to break, because they think it's a lot of finances. We don't have enough food. Thank God our mayor was able to donate food for their stay in the hospital every single day. So eventually, we've also found out he had POTS disease or extrapulmonary TB, and that was the reason why he couldn't walk. But now, fast forward 2024, this is him now. That's Joseph. That's his profile picture on Facebook. This is all taken with patient consent, by the way. So he knows he's here. And now he has a girlfriend. He's living a normal life. He's able to help in the seaweed farming business of his father. Imagine if we didn't listen. I just said, no, it's too difficult to go there. He would have been dead right now. So again, we're dealing with lives here. When we find the missing TB cases, we look for them in the places where we wouldn't think, where doctors wouldn't necessarily go. That's how we find the missing TB cases, and that's how we save lives. Thank you again, everyone. Madamong nga salamat sa aton tanan. You can scan the QR code to add our Facebook page, facebook.com/bantayanhealth, and that's my Email samantha.tinsay@gmail.com. If you want to go to the island, let me know. Thank you.
Thank you, Dr. Samantha. I think really your passion was kind of reflected in the presentation as well as the spectacular kind of journey what you are kind of trying to transform the place. So any questions for her? Yeah.
I was looking at the urban, but before that, wonderful presentation. Thank you so much. I was looking at the urban-rural divide in Philippines. You know, as we know, Philippines has some of the largest cities, and the density of the population is very high, with almost 2% of population moving into these cities. But the disease notification doesn't seem to be reflecting of this movement from the rural areas to urban areas. Why would that be? Is that the urban population are not getting so many tests done, or the rural population are getting tested more because of all of these interventions?
I'm just going to speak for Bantayan. I can't speak for other local government units, but just based on our experience, apparently we are testing more than urban areas just for our particular project, because my staff, whenever I say let's go, they're willing to go. There's no like fighting, there's no discussion. We just go. Like tomorrow, there's a case finding. They're like, can we rest? Or like, okay, the DOH is gonna get. So background, the Department of Health owns the ultra portable, and they're like, we want it back by June 10. So now we're scrambling to get all the case findings done. But apparently in other cities, like in Manila, they do a lot of screening. But unfortunately, they don't have enough medication. So people are complaining. This is from my friend that works there. People are complaining, why are you screening me when you can't treat me? So that's another issue. So in the sense, in our case, we screen when we have the proper medication. We don't go out in the field if we don't have the appropriate supplies, because I don't want to give someone anxiety for 6 months, right? You don't want to say, oh yeah, you have TB, but we don't have any meds.
Yeah.
So what do you do then, right? So it has to be a full package. Yeah. And also another thing with the urban rural, because of the pandemic, a lot of people that were living in the cities moved back to Bantayan. So they were also exposed in the bigger cities because they ran out of money, they didn't have a job. So a lot of people actually moved back during the pandemic. Okay, yeah.
Yeah, so 3 questions. You first, second, and third. Yeah.
Okay, thank you very much. That's a touching story. I think that's resurrection. Well done. I'm just wondering, I'm seeing from a couple of pictures so far. When you are screening, you are using X-ray in the open. I mean, from a scientific point of view, I do understand it's low dose and things. But from where I come from, and probably the rest of my colleagues here, it seems a very difficult issue to convince authorities to start with, to just talk about mobile X-ray. I just want to understand from your experience how you manage to navigate around that, or is it a matter of maybe your laws in your countries that maybe are favorable to a bit relaxed? How have you managed to convince the authorities on the use of radiation in the open?
Yeah, so in this case, I am the authority. Sorry. I work for the government. I'm the municipal health officer. So what we do, we do it out in the open, but we have a perimeter of 2 meters around. So we tell people don't go there. We make sure we don't do it in an area where there's pregnant patients or any like children running around. So that's what we do. We work with the community. We do a social prep before we go in. And we tell them we're doing this. It has a little bit of radiation. We need to keep a perimeter around. Can we have we call them barangay tanod, or the security, make sure no one breaches the parameters when we do the screening.
Yeah, maybe I would ask for more like pictures, videos if you have, so that we can also convince our officials there back home you cannot start that conversation at times. They'll
Yeah.
just dismiss you. No X-ray out there, but I can see the obviously the impact it has.
Yeah.
Yeah.
Because most people back then, I mean, back then meaning in 2021 and before that, they were not getting screened. They were just people dying of, they said, oh, barang, which means in Bisaya, it's like witchcraft or voodoo. Someone did voodoo on them. So that's why they're dying. No, it's MTB. So in this sense, we tell people, we do the social prep. Social prep is very important because you have to get the community members who are in that township involved. You can't just go in there and like, oh, I'm coming in there to save you. No, you have to work with the people in the community because you have to make them understand and educate them why we're doing this and what the risks are, just like any medical procedure, and what we expect out of it. So in that sense, I think we can discuss this a little bit more if he wants to later. Yeah.
Thank you. Just to echo the other presenters, thank you for again bringing the humanity, towards the management of TB patients. It's really inspiring. Do you initiate TPT?
Yes, we do. So if, for example, someone is bacteriologically confirmed, DSTB or even DRTB, and then we check their whole household for TB, and if they're negative, then we start them on TPT. Unfortunately, in the past 2 months, the Department of Health ran out of TPT. And I don't know where to procure them. So that's our caveat right now. But we do that. But if it turns out that they also have TB, then obviously you have to treat them for tuberculosis as well. But that's another point of contention in the community. They're like, I tested negative. Why do I have to take treatment for 3 months? That's another issue also. Yeah.
Because for such a community, it is such a great opportunity when we talk of TB elimination. As we treat, we also provide that prevention for the entire community.
Yes, so we also do that, but unfortunately, they ran out of TPT in our province. So we're waiting on the next batch of that, but we have a wait list currently for that. Thank you for that question.
Thank you very much for inspirational and excellent work. I get inspired, and thank you. So I think you are providing a mobile service in the community. So how do you manage what's the electric, the power system for your TrueNAT and digital X-rays?
Okay, so thank God all the islets in Bantayan have electricity. But if they don't, it happened to us once where the electricity got cut off. Unfortunately, we had to stop operations because like the power, it comes with a power bank, but the power bank could only last like maybe 4 hours, 5 hours. So that's the caveat. So having solar technology, there's a lot of sun in the island, would be very useful. So maybe we can talk more about that later. As a backup, in case the power grid goes off, because it has happened a couple times, especially during the pilot, because it was typhoon season. So the electrical grid was a bit unsteady that time. So having a power bank or having solar would be really good, actually.
Hello, Samantha. It's just a wow. I want to salute you. Actually, what motivates you to do these all things for the unreached people? I just want to know. Thank you.
Yeah, so actually, I wanted to be a scientist. I was waitlisted at UCLA for biochem. And then this program in public health opened. I was like, what is public health? I don't even know what that is at UC Irvine. I'm glad I took it. I'm glad I listened to my mom and my gut. What motivates me is maybe it's because it runs in my family, public service. I just seeing the people get better every day. I'm not doing this for money because I don't get paid that much, but the government, unfortunately. I do it because I see that these people deserve a chance. Yeah, because of universal healthcare in our island, we try to make sure even if you're rich or you're poor, whatever you are, we treat you the same. Not, oh, that's a public patient. You don't check them all the way. Oh, that's a private patient, or that's the mayor. We have to treat them better. It's not about that, because at the core of each and every one of us, we are the same. Right? Just look at someone's eyes. You're the same as them. You can strip the status, the money, the culture, whatever. At the heart of it, we are humans. And so you should treat everyone with the same amount of respect.
So, thank you.
Thank you.
Thank you, Dr. Samantha. I think that was a really good, inspiring session. And I'm sure everybody has learned a lot in addition to what you have taught the Mayong Aga. So we will remember this word. So what we are going to do now is we'll break for 10 minutes. Let's have a tea break, stretch out, and then we'll come back at around, so let's say 11:40, 11:45, we should be starting again. Thank you. Thank you so much for your attention.
neighboring my brothers, Kenya, Tanzania, DRC, and South Sudan. And we are a population of 47 million, that is estimates from WHO. Our current incidence is 198 per 100,000 population. And that means that every year we should be notifying an estimated 94,000 cases of TB. So we're going to share our experience on iNTP implementation, especially in TrueNat. Next slide. Sorry. Okay, sorry. Yeah, thank you. Oh, is it okay? Very good, thank you. So this is basically our diagnostic landscape as it stands. We have about 1,800 microscope patients with 292 expert, 41 TrueNat, 17 sites with TB lab, and about 1,000 doing LF-LAM, and 3 culture labs, of which, so 5 culture labs, of which 3 are research and 2 public health. We have an integrated specimen referral system that relies on the hub and spoke model, and currently having a connectivity solution called Lab Expert that are able to link and support us in monitoring the diagnostics and also support linkage of patients. In 2022, we had the support from iNTP, where we benefited from 38 dual TrueNat instruments and about 70,000 reagents. And we were able to have consultative processes which guided the placement of these tools. And we're focusing on our PHC facilities, which are basically health center 4s and 3s. And our focus is looking at facilities that have a high OPD attendance, but also considering the distance from the gene expert systems. So we started by supporting centralized training, and we got support from USAID IDDS, and that is Professor Grace, where they were supported us during the training of teams from the NTRL, Ethiopia, and the supply chain. And then we did a super user training looking at the regional labs coordinators at NTRL to be able to support the on-site training and the supervisions. Okay, so in terms of the on-site trainings, these were done on average of 2 days per facility, supported by the super users and the mobile vendor and then TOP. And we are targeted training the doctors, the clinicians, laboratory staff, and the data and the stores in comprehensive management of the TrueNat aspects. And also involve the regional supervisors and implementing partners to ensure that there's more awareness in use of the TrueNat. So that's right. Oh, it's okay. Oh, thank you. So in terms of training, we made sure that we also address other aspects of the outreach communities. And these are the for some of the facilities that were visited by Bashir and the team in the islands. Then also be able to do support supervision in our facilities to make sure that there is uptake of the technology. And currently, we are able to integrate this in our ongoing laboratory support supervision that is carried out by the NTR, but also by the department. Last year, 2023, we were able to get support from the Africa consultants, which supported us to do country-wide service and refresh training, because we had a period when we didn't have stock of TrueNat reagents, and therefore it was very important to refresh our facilities in the country, and we appreciate the consultant led by Daniel. So in terms of improving access, we have mentioned earlier that we have a hub and spoke model that is supported by the motorcycle bike riders that move samples from the lower facilities that have MWD tools like TrueNat, and then those samples that really need culture move to the central testing centers. In terms of data management, we've been able to do a number of things to make sure that we incorporate TrueNat within our data management tools, and we have the revised HMIS tools that have been worked on and currently going to be rolled out, and being able to bring on board incorporating TrueNat within our connectivity solutions. Where we're having currently the gap is that our systems are currently offline in spite of having data, and we need to see that we address this gap. In terms of external quality assessment, this is a very important aspect of testing. And IDDS earlier on supported us to have all our sites enrolled in Smart Spot, the South African HOA system. But we are happy to say that in the country, we now have been able to develop our HOA program for TrueNat. And this program is being used to support other countries within our SRO network. Equipment maintenance, this was a challenge in the beginning where we had a lot of delays from the vendor then, but we are happy to see that Mobile supported us, and there was change in the vendor, and we are currently able to get monthly reports, and I would say that we are now back on track in terms of our service and maintenance, and thanks to BioHealth that is led by Bashir and the team. So what we see as the current impact in these facilities, the 40 facilities are doing TrueNat. We can see that in 2021, we had about 2,100 cases of TB before introducing TrueNat. But you can see an increase in 2022 when the sites were fully up and running. And then you could see a trend in bacteriological confirmation in these sites. You need to note that in 2023, we had a period of stock out. That's why we can see a drop in cases. But now this year, everything is stable, and we expect to see the cases continue going up, but also improving bacterial confirmation. But also on top of that, we receive reports from end users in terms of having to be able to do same-day diagnosis and treatment initiation because of the reduced turnaround time that they observe in these facilities. So on putting that aside, these are some of the things that we pick from the end users that we talk about, the lab technicians and the district managers in terms of their concerns or feedback on using TrueNat. One of the things is the power. We know that the tool has the battery, but in our settings where we have facilities where power goes off for a day or 2 days, then this may not be able to support uninterrupted testing. Then we believe that if we are to improve and able to have access to molecular diagnosis for the presumptive TB testing, then issues of the cost of the equipment and the cost of the reagents need to be looked at, comparing with other tools that are available in the market. Then in terms of the warehouse, we have a meeting where we discuss these issues. The national warehouse that handles the distribution, the storage and distribution, believe that we need to look at the bulkiness of the supplies, because in terms of the space and the distribution in the network, so that there is seamless supply chain. Connectivity, what we realize that if you connect the system to internet and the connectivity solution, you don't have backlog data uploaded on the server or on the system, so you lose out on data. But also, it seems that if there is a change on the side of mobile, then the systems on our side get disconnected. So for over a month, currently we're not able to upload data, and the process of IT support seems to be slow. So this is something that we need to look at to have a seamless transmission and be able to use this data for decision making. And Second last is in terms of our setup, is that most of the facilities where we plan to put these equipments are either understaffed or the staffing there is low cadre. And therefore, if you are to improve uptake of this tool, then you need to reduce the hands-on processes so that the quality of testing is improved. Because the more they do hands-on, then the more risk errors. But also in terms of the time they take to process the sample, so that you are this one or two lab staff that are in those facilities are able to handle TB, malaria, and other tests quicker. So that is something we need to look at, reducing the processes of testing. And lastly is to address the aspect of about disease testing, because most in our country, our government is looking at reducing the proliferation of tools in the laboratories. So the more you have one tool that's able to do TB, virology, then you are able to probably save on the cost of the equipment, the servicing, and other aspects that go along with this. Having said that, this is one of the quotation from our lab technician. TrueNAT testing has more hands-on work compared to gene expert. Since we are only 2 staff in the laboratory, it is going to be quite hard for us to manage the workload. However, due to the delays we have been experiencing when referring samples to gene expert testing, we see this as a better solution for our patients, since we can now ensure same-day diagnosis. So what we are seeing that in spite of the room for improvement, the technicians and health workers are appreciating the tool because it gives them opportunity to be able to provide molecular testing where the gene expert was not reaching, and where they can be able now to replace microscope and be able to sensitive test. But they believe that the company and other players can be able to improve this and be able to have better access to our population. These are our partners that we appreciate: USAID, Stop TB, IDDS through PATH, Mobile, and BioHealth Africa. I would request to give 1 minute to my colleague Raymond to just give us a plan on how we move forward beyond the iNTP project. Over to you, Raymond.
Thank you very much, Abdunul. Dr. Raymond Biarhanga. I work with the Ministry of Health, the National TB Program, as a senior technical advisor. So we have had this technology for the last two years, and we have been stuck at 41 machines. We have a scale-up plan that we would want to see more of this technology at lower level facilities, as Abdunul has said, in terms of, because of its easy to use, electricity, challenges are shortened, but also because it is one of those technologies now that is available for us. However, as a country, we had 2 changes in policy. Number one, we have insisted on making sure that all our presumptive TB cases must have a molecular test done. So we take advantage of TrueNAT being available. But 2, and more critically, is that the country has also taken another step of making sure that there is no more procurement of equipment. And this came from the highest office of the president and has been resounded by our permanent secretary, to making sure that if there is an opportunity for placement and we buy and we are then able to procure the reagents or the cartridges, that would be much more of an advantage, even if it's putting a factor of making sure that the cartridges are more, so that we can be able to, it makes business sense as well to the company. So as a result of that, because of those 2 policy changes, we have started discussing with our partners to see that can happen, because we have the population to look out for. We have had a huge shift in our presumptive case finding. which means that actually even at community level, we are doing a lot in terms of identifying a lot of TB through our, if you've heard of our CAST TB campaign, where we actually in a week, we can have more than even 100,000 samples being tested in our labs. And most of them, we want them to be tested by a molecular test. So as a result of that, we are looking to expanding our molecular test beyond just the available TrueNut machines to adding more machines, as long as we have the availability of that partnership in terms of placement. So that is what I can say in terms of our expansion plan. And we look forward to any comments or questions that might come. Thank you very much.
Great presentation, I think. Yeah. Any questions from the house? I think more on their like learnings and are like emerging at a similar pattern like with other countries and so, but yeah, I think I see one can, please.
Hi. So this is not a question. This is just to kind of take the request from you and the one that Professor Joloba made yesterday with regards to the rentals, the placements as you call it. So, one guiding learning that we all have is that nothing comes free. So at the end of the day, whether it's SmallBio or any other company, someone's going to pay for either the manufacturing or whatever. Placements also have different dimensions because it's not that the capex is not really recovered. They are recovered by adding a surcharge to the cost of the test. So in terms of TB diagnostics in the global context, the prices, etc., are already kind of very, very well negotiated and kind of very, very reasonable as of now. And other companies have also dropped prices, as we all know. So I think in that respect, and SmallBio doesn't have any refurbs. That's kind of machines used in other countries that have outlived their longevity or life and now is available back to SmallBio, kind of do a refurb on them and give it back to other countries at a lower cost or maybe with no cost at all. So that is not even the case with SmallBio as of now. So what I was just wanting to say, and this also to Professor's request yesterday, sir, while we would as a company be alive to this request, and as and when the time does come, and if it is possible for us to handle such requests, we will. But as of now, and at least in the near foreseeable future, the way of placements, at least from our end, looks a little difficult. So I think the country should plan in such a way that the placement part of it, of course, if the local partners of SmallBio are willing to, put in the money and do a placement, they are absolutely welcome. And that's also showing a lot of skin in the game as far as they are concerned. But for us as a company, which is kind of just getting started, it looks a little difficult as of now. Thank you.
Appreciate and I just wanted actually to even add some more information. I think it was last year we had a budget that was put under USAID to procure, and I think we brought in more than 80,000 sample cartridges for TrueNut. But unfortunately, because we didn't have enough machines, we are very cognizant of the expiry next year. So we have had to ask other countries, I think like Tanzania, to take them up. But that has now cost us in terms of reduction of the cartridges that we're going to procure in the next year and maybe in the next 2-3 years, simply because I think we don't have all the machines that we need. So that's a bit of a challenge. It's a catch-22 on either side. Thank you.
Hi, thank you for the excellent presentation, both of you. My question is a comment and a question as well. I think the first policy is very scientific, timely, and convincing, having a policy that requires every TB patient to have access for molecular testing. So that's the super work. It's a paradox as well, with a limited number of machines in a country. The highest political leadership is also placing a cap, no more procurement of machines. So one, it is a paradox, and the question related to it is, what's the rationale behind to limit us from procuring these growing machines? And the science is getting dynamic in the TB community. We might advance even existing small biomachines even, you know. So there should be a room for, you know, advancing and qualifying what we have now. And I just want to understand what is behind and the rationale justification for the head of the state to limit the procurements. Thank you.
Okay, thank you very much for that question. You'd want to supplement before I can?
Yeah, just to add on to what we discussed earlier, Malbio, of course, is providing additional machines without charge to all its country partners without even being asked, so that there is adequate standbys in each country. And in terms of need, in terms of emergencies, those could be used by the program, you know, without any sweat. So wherever possible, Malbio is already alive, as I said. So we are providing several units without any cost to our country partners, every country, so that there are standbys available. Machines, if and when they do have problems, don't have to travel out of the country to get serviced, as has been the experience that has been shared in the past. There are country-trained engineers, spare parts availability right in your own doorstep. So just as a follow-up to let you know that there are machines available, again, for which Malbio has not taken any resource from anybody.
Thank you.
And those can be utilized by the programs.
Thank you. Thank you. And I appreciate that that question.
Thank you very much. Facing policies within the country regarding on the way forward. And the national TB programs need to be aware of the international collaborations taking place globally through the Global Fund, through Stop Partnership TB, through the TB Alliance, through USAID, through PEPFAR. And what you need to do is that you need, as a program, you need to align yourself with these programs globally, because some of these equipments coming from mobile are basically more of support from the collaborating partners. If you are aware that in 2018, there was a high-level meeting in United Nations, whereby each and every country was given targets to end TB. And the solution to end TB was basically to have tools which are available within in-country, which will help United Nations to end TB in 2030. This was a follow-up with United Nations, also high-level meeting last year in New York to report back the progress. So it is a matter of an initiative from the ministry itself and the program itself to align itself with the requirements of the United Nations resolutions of ending TB 2030 and having tools within the countries to make sure that we reach every infection within the country. So my suggestion is, as a TB program of the country, you can make requests and through the ministry and the collaborative ministry within your country to see whether you can be able to access these funds to support your program. And at the end of the day, you'll find that There are several mechanisms through global drug stores, through TB Alliance in Geneva, and you still find that the procurement does not necessarily need to be based on government policy. The procurement is a support to make sure that we align yourself with the request of the United Nations on ending TB 2030. And I believe there are many ways. So as the programs within the country, the government of the day, they have the will to give the guidance and policy, but also you need to think outside the box to make sure you also help the government to achieve what they want to achieve without spending money, but the money coming from the donor community and the programs globally. Thank you.
Yeah.
No. Expanding on what my colleague just said. So there are other sources of money. One is what he suggests, look at other donors. You are only looking at Global Fund and USAID. The other donors, one example is what USAID is doing in our country, that corporate TB pledge. So they are encouraging all for-profit companies in the country to do some donations, some corporate social responsibility towards TB program. So I think how many 400 plus for-profit companies involved donating to TB in whatever form, nutrition, equipment, drugs, etc. You have to reach out to them and do that. That's one. Other is what we generally do is look at TB preventive therapy. Who gives TB preventive therapy in HIV positive patients? It is the HIV program. In our country, the HIV co-infection rate is very low, 3%. Still, they give TB preventive therapy. So in your countries, the co-infection rates are close to 50%. Now, if you want to reduce death in HIV positive patients, you have to detect certain diseases very early and do that routinely. You have a list of 50, 60 diseases which you screen for all HIV patients every year. TB is one of them, most common. So you can actually leverage on HIV program to fulfill your needs. That's what the collaboration is. TB HIV is a huge collaboration. So that's what most people do.
Yeah.
Like we have a TB diabetes collaboration, but the diabetic kits are coming from the diabetes program. They are not coming from the TB program. So you have to think, as he said, out of the box, see where are the possibilities and do that. We'll also let you know how to actually tap resources, etc. Sometimes later, maybe tomorrow, how to look at corporates and other sources of fund, even sometimes high net worth individuals for donations. We also have in our country what is known as Member of Parliament's Local Area Development Scheme. They get some funds to support community. Those funds can go into road building or those funds can go into your TB program. It's up to you how you leverage on them. How do you engage with the elected leaders? So there, think out of the box, we'll be able to find resources.
Thank you very much for those strategies, especially around the public-private mix.
Okay.
Yes.
Okay, thank you so much for the presentation. On the resources for TB, I think most countries, for example, my country, Zimbabwe, we are in the phase where we are doing sustainability frameworks for the country. And the agenda of domestic financing should be part of TB. Our countries, most of them, like Southern Africa, are pushed by artisanal miners with a lot of minerals and so forth. It's a high time we should also push domestic financing to also fund some of these innovations. Thank you.
Yeah, thank you. I just want to say, yes, the private sector is one of those that we are doing, but Uganda has also increased its domestic financing, but in the context of making sure that supplies are available. I'll give an example. For example, now Uganda pays 100% for its drug-susceptible TB medicines. We don't get any funding from the Global Fund. We have also moved to increasing the gene expert cartridges that government of Uganda procures to about 10-15% of the cartridges that the country uses. So about 10-15% are through government of Uganda. And then the TPT as well. We've been using isoniazid. Now we are moving to 3HP. 3HP currently is still slightly more expensive than INH. So we're now trying to move policy in that direction. But what am I trying to say is that whereas we are increasing domestic financing towards TB, there is the notion that already what is available in the facilities in terms of the backbone of the gene expert machines that you saw, about 290 machines that are there. It's what now government is looking at. And it's mainly looking at that because of the multiplexity that Abdul Nula has mentioned. The fewer the machines in the lab, the more they will tend to look at that approach. So if you bring in another machine, as if it's doing multiplexity, it's at a lower level facility, it will be highly considered, like a TrueNat. If we can have additional, tests being done on it, that would be an advantage to that. Now, and even the gene expert machines that we are now looking at going forward, they are looking at placement process than procuring. So we have that catch-22 against procure, and the Global Fund is not looking at adding more machines. Actually, most of our machines that we wanted to procure under GC7 have all been put above allocation as priority, but above allocation. The only thing that I think we're able to procure today are the additional extra machines that we are getting in, and it's still under the COVID grant, rollout COVID grant. So we will continue to negotiate, discuss, but also we're looking forward to what our brothers and sisters from Mobile will bring forward for us. Thank you.
Thank you. I think these were really good and useful interactions. We are actually running late, very late. Okay, your time starts now, 60 seconds.
Less than a minute. Hello. Yeah, just adding to what Dr. Sachdeva said and the rest of us, we were discussing, thinking out of the box. One, of course, this is a forum on, on TB, but one could also look at other, programs, national programs within the country as well, since TrueNat in itself is a multi-disease platform, right? It can test multiple diseases. So one can look at collaborating with other national programs as well. That's, that's food for thought there.
Great, thanks. So we'll move to the next presentation from Ethiopia now, and I'll request Mr. Aga to come here and make the presentation.
Okay, thank you very much. Mine is focused on the comprehensive TB program activities, and I am basically I'm a lab technologist and then a public health specialist. So my presentation includes both the programmatic part and the lab service. Thank you very much. Okay. So mostly the TB burden, due to the time constraints, you know that the WHO reports and the other global reports, you have seen that. So I just run next, please. So these are the backgrounds, the health profile for the country and the burden, and the implementation of the molecular test, yes. Starting from the very beginning, machines, and then up to now. Then the contribution of the molecular tests so far, and the expansion of the molecular tests and the test multiplexing, then challenges and the opportunities we have. Okay, this is a profile. Some of the data are not good, actually, especially the TB microscopy. So we have a lot of hospitals and health facilities. As you know, Ethiopia is a big country with 120 million population. And gene expert and the TrueNAT, let's focus on these two machines. And so about 663 machines for gene expert, and mostly they are procured by support of USAID. Almost 50% of the expert machines and TrueNAT were procured by support of USAID. Thank you, USAID. Just a big applause for them, please. We have TB culture and regional laboratories. In addition to the national TB reference lab, we have 14 regional labs and about more than 1,000 actually private health facilities. There are 8,000 private health facilities. Among these, about 2,000 are supported by the national TB program, the so-called PPM, public-private mix. And the MDR TB treatment initiative centers, 69 hospitals, and treatment follow-ups about 800. So as I said, the population is very high, and the incidence is about 126 now in 2023. This is the report of 2024. In 2023, the activity was done 2022. And the total notification is about 73%. And the treatment, the direct susceptibility treatment coverage is about 92%. And with documented HIV test, about 85%. And the co-infection with HIV is about 72%. The newly enrolled for HIV positive on TPT, it's about 64% coverage, and the co-infection is about 5.2%, and the number of the mortality is high actually. The total MDR annually, we are detecting about 882. So still, we have to work hard to cover all this. 37,000 population are not reached. So we are missing them still annually. So this is the global TB progress according to the report. And so we are almost getting our targets. So when we see the trends, we are about the incidence is decreasing. The death rate is also decreasing. But when we look at the 2022, both death rate and the incidence rate is increasing due to different reasons. For example, the droughts, or the natural disasters, the conflicts, the number of the refugees and the returnees, and so increased. So in last year it increased. So now we have to plan in such a way. And the death rate for drug-resistant TB is also high. It's about 9%. So we have to work hard there. When we look at the 23 years trends, the annual number of notified TB cases is like that. So still we have a gap. The WHO estimates and that's the number of we are detecting, notifying is still there is a gap. So we have to cover this gap. These people are living in the country. They are distributing. They are okay. They have TB. They are. So we have to reach these people. These people are at the periphery of the country, in the prison, in the holy water, in the churches, in the prison, in the universities even. So school TBs, there are a lot. So we have to reach all these people to notify. Major changes are now updating our guidelines. So the chest X-ray screening is very important. We have visited yesterday the company. So this simple and very small and well scientific equipment should be procured and distributed for the community. So screening should be started from by the chest X-ray. The TrueNAT and other molecular diagnostic algorithms should be included in guidelines, and the TB lamp also included in WHO recommends not all the molecular tests replace the microscopy. WHO recommends only for TB lamp. Okay, so TB lamp can replace gene experts. So we will expand and actually we didn't. We started only at 4 or 8 sites this year. So we will expand it also for other molecular tests. So we will expand them also. Childhood TB also for different diagnostics should be designed for childhood TB also. And also genome sequencing also worked at national level. When it comes to the lab part, it's always, we say that it's the backbone for the TB diagnosis. It has to be true, okay? There are a lot of major roles for TB program. As you know, it's early detection and early treatment. We have seen yesterday presentation from Geneva. So these two are very important: early detection, early treatment. So the lab plays a role on this. So resistance strains will be detected, monitoring will be done by the lab, and for epidemiological surveillance data, and also play in disease prevention even. For example, if you look at the MDR TB, Ethiopia is currently out of among the 30 high burden TB countries for MDR. We are out of that. So this is due to the molecular tests we are working on. And also, it's very important for planning for the supply. So as someone said yesterday, if there is no lab service, there is no lab, no TB program and no treatment. This should be the motto for us. Okay? Okay. So as I said, nationally, we took all this in our algorithm. All these technologies are functional now. And additional supporting diagnostic are also included in our guideline. When you come to the TrueNATs, we have 15 actually, which are functional, thanks to MolBio. 10 were provided by the MolBio. Even they changed the version, the old version to the new version, 5 of them. And the 5 were procured by the USAID partner. And now we are ordered 15. And also for 50 machines also we have confirmed budget. So we are expanding to it. This is implementation for molecular tests. And when it comes to the diagnostic technology transfer, we have to consider all this. Firstly, WHO endorsement should be there. It has to be very simple and near to the patient. Very complicated machine. Even the professionals are not need such type. So simple technology should be there. Biosafety issues should be considered, and rapid and accurate results from that technology. So automated in real time, able to detect at least rifampicin and INH, at least. We are from the poor countries, you know. This is the third world countries who are suffering from TB. So budget constraints are there. So we have to combine our technologies to detect both the MTB and the rifampicin, the drug resistance also. Okay, and they have to be robust. and the multiplexing at least with some of the major diseases. So these are the examples actually. That's what I said. Ethiopia is out of the MDR TB currently among the 30 countries. These are the performance of Gene Expert. This is as example because we serve the Gene Expert machine served for more than 10 years. So we have data now. We will include other molecular tests, including the TrueNAT also. Multiplexing, we have started with Gene Expert. So the companies should take consideration for multiplexing of the machines. So there are gaps, actually. There are many gaps. These are major gaps. We still missed TB cases. So affordable and effective programmatic implementation should be done by the countries. High initial costs. In Kenya's presentation also it's presented. Initial costs and laboratory needs huge budget. Therefore, companies or manufacturers should innovate for leasing, for placement, and so on. So the countries can procure reagents only. So we have to think out of the box, okay? And electric power, it is still our challenge. Therefore, the package, when we procure the machine, we have to think of the package, like UPS, solar panels. The countries can pay, okay? We have experience. I'll come to at the end of my slide. So lesson learned for the last 5 years, these are very important issues. Household contact started catch-up campaign. These are very excellent performance for our country to go to house and detect the TB. TB is in the house, not in the health center currently. Therefore, we have to move in such a way. Congregate setting, unreachable people are there, so we have to reach them. We have to plan in such a way. And fully equipped mobile vans, these were excellent examples, and we want to expand this. TB supplies good, and there are commitment. Local budgets are started by the local governments by regular budget, in addition to Global Fund, USAID, and other SDGs. So, and how to manage TB program during different challenging time. Internal conflicts are there, droughts, COVID-19, refugees and returnees. We have a lot of people returned from Saudi Arabia to Ethiopia with different reasons. So we are managing them. We are providing machines for them. We are providing drugs for them. Okay, we are expanding health facilities to that areas. So we manage it. So this is a good lesson for our country. There are a lot of opportunities. Molecular tests are expanding. Competitive machines, countries should have alternative machines. Okay, so leasing, some of the companies are starting leasing or placement. So we have to think, MolBio should think in such a way, because all of these people are from the third world who are suffering from TB and other diseases. So we have to think of the community. Okay, technologies can be multiplexing for multi-disease. So in such a way, this is a good opportunity for our countries. Possible to make service level agreement with companies. We have experience. So therefore, maintenance issue should not be a big deal. The companies should install, train, and should maintain. The responsibility should be for the company. The countries can buy the service and the pay. Okay. Otherwise, the health personnel should not go for maintenance or something else. It should be the responsibility of the company. So we can make agreement. Okay, our future plan, still we want to expand molecular tests to 1,000 districts till 2026. All molecular tests, okay? And also PPM is very important. TB is for everyone. We have more than 50% of TB cases detected at private health facilities, especially in big cities. In big cities, there are access for specialists, access for the equipment. So people move to the private clinic. So we have to support for these programs. Private facilities should be supported, so we have to strengthen there. Referral linkage, it is very important because we cannot cover more than 4,000 health facilities by equipping them. So specimen referral is very important. So we have to work hard in such a way. For example, this is a mobile van for pastoral community. Ethiopia has a lot of pastoral community like Kenya, the border of Kenya, border of Somalia, and the border of Eritrea. There are a lot of pastorals. So mobile clinic, which is equipped with X-ray, with molecular tests, with microscope and refrigerated, all these packages are found in this van. So we have to support them because they don't have a regular address. They just go with nature, okay? Follow the rain, follow the grass. So we have to move with them. We have at least 4 machines in pastoral area. This should be expanded to the other arid areas also. Thank you very much. All these organizations, directly or indirectly, support TB program. Not only the lab, the equipment, all the programs. Thank you very much. I don't know something. In the interest of time,
It's just to complement 2 things. One is the calendar. When you see 2012, 13, we're 7 years younger than everyone. So just for you guys to understand, when Getachew refers to catch-up campaign, Ethiopia has undergone with the different shocks, natural, man-made, and we have to catch up with the losses in those conflict, drought, and COVID eras. And since the purpose of this presentation is on iNTP project, in Ethiopia, the iNTP project has supported the country with a connectivity solution. We adapted it from Uganda. Thank you, Uganda colleagues. And we owned it with full authority. It provides real-time data for the administration, the whole of health administration. It also reports the health of the machine, whether it failed or not. It can provide real-time information for the clinician and for the patient. And it can also provide supply chain data to the authorities. So this was supported with iNTP. I just want to complement that. Thank you.
Thank you for the presentation. Mine, I think there are just 2 questions. The first one is, I've seen an ambitious plan, future plan of 1,000 districts, equipping them with molecular tools. I wanted to confirm who is supporting this? Is this your government or is this donors, and the possible timeline? Then number 2, I've seen a lot of public-private mix in your slides. How does it work in Ethiopia so that other countries potentially can pick a leaf from that? Thank you.
Okay, thank you very much. Thanks, Dr. Yorso, for additional inputs on iNTP. Yes. By the way, I think from East Africa, we were the first to use lab experts. From the engineer was from Uganda. I think Professor Moses, you can support me. The guy is from Uganda, but Ethiopia used it before Uganda. Really? Anyway, now we are using it. So the lab experts connectivity was for almost more than 100 expert machines, they are connected, so we are expanding it. Also, we include for mobile products, we included it officially. So in-country medical, polypharma engineers are connecting the TrueNAT with iNTP. With the ambitious plan, we have to stretch. Our plan should be stretched, okay? We have about 700 machines now. We left with 300. These 300 will be procured soon. All the molecular tests, includes the gene expert, includes the TrueNAT, maybe others, according to our budget, and also because we include in our guideline. If you include the technology in your guideline, partners can support you. If you don't include the algorithm in your guideline, no one can support you. So we include, so any partners can support us. From the government side, we have a plan to procure more than 300 machines in the next 2 years. That means 2026. It was already included in our strategic plan, so we can do that. Okay. We have more than 1,000 districts. Still, we have left with about 130 districts without any machine. So we have to reach there. The big challenge is electricity. That is why I am focusing on the solar panel. For PPM, yes, there are a lot of private facilities. There are criteria to include us as a PPM to be supported by the TB program at all levels. Therefore, we are previously for the last 10 years, it is already only about 400 private facilities. Now we are expanding with the criteria. One of the criteria was requests for the voluntarism of the clinic, private clinic. If they are volunteer to serve TB, we include them. Now, about 2,000. Among 8,000, 2,000 are supporting TB patients freely. Okay? 2,000 over 8,000 still, it's very small. It's very small. The contribution of PPM is about 17% among all the case notification. 17. Okay? It's very high. 17%. Thank you.
One last question, please. Very brief, yes. One of your slides talked about the module failure rate in about 663 of these gene expert machines that you have. Running a quick mathematical analysis on that, and assuming that you have 2 module instruments right across the board, you are looking at about 1,320 modules running simultaneously. And with a 48% failure rate of modules, you're looking at about 620 modules being failed. My question is, have you done an analysis on the downtimes of these modules? And as a result, how does it impact your procurement on these cartridges? Will that not also get impacted in terms of timelines, in terms of availability, etc.?
Okay. Thank you very much. Surely, from this machine, the big challenge is module failure, as you say. Module failure is a big challenge. What we did is, we have agreement with the company. So procurement is done by the company. Okay? We will pay them when we procure cartridge. We add the cost of the maintenance as a surcharge on the cartridge. Therefore, we have a KPI. A monthly discussion is there with the company. Therefore, we'll discuss. And also, they have office in capital city Addis. And also, we want to assign biomedical engineers at all regions, at least at regional levels. Currently, they are working at national level. We are forcing them to do at regional level because health facilities are too many. The machines are expanded. Therefore, we have to have biomedical engineers there. Otherwise, you have to capacitate other biomedical engineers in hospitals. Therefore, we have agreement to replace any module failure within 2 weeks. That is agreement. Okay. Any addition?
So, not representing the government, but just an expert's opinion. So, module failure is a big secret that no one can hide for gene experts. Those numbers are disturbing numbers. And in some instances, it took us like 6 months to replace them. So the first thing is by design, the technology is, in my opinion, designed in a developed world, and definitely that requires a continuous work in the developing world. A big lesson for other developers. At the same time, despite our service level agreement, which we are charged for our cartridges, we continued to suffer from the failures and the delayed replacements. That's the hard reality that we are all facing. So I think the future is for a technology that doesn't require such a requirement. And if we have a technology that will not be requiring frequent failure calibration and replacement and a service level agreement that charges us millions of dollars for a developing world, that's going to be a choice for everyone, not in Ethiopia, but everywhere. And this is a big secret, seems a big secret, but it's visible for everyone. I just want to speak about it. Thank you.
10 seconds. Thank you for your presentation. Just wanted to add that we have already provided the solar solution. It is part of the Global Fund. I can say that Nigeria, which has procured 300 plus machines, are also getting 300 solar solutions. It will soon be part of the Stop TB-GTF catalog as well. So the solar solutions are now available for all countries to procure.
Okay. Okay, thank you. Thank you again. Nice presentation and the discussion. So I've been informed by the organizers that until we finish all the presentation, there will be no lunch. So it is up to us now. There are 4 presentations before the lunch. So I will request everyone to be precise in their comments, questions, and also in the answers. And also request her to be very vigilant. Let's stick to the time because nutrition is something very important factor. We should not also neglect our nutrition. So with that, I'll request team from Bangladesh, Dr. Shaila Islam, to kind of come here and make a presentation. Over to you.
So good afternoon, everybody. I'll try my best to do the brief of my presentation as much as possible as time is concerned. Yeah. Yeah, so like my previous presenter friends, I will have a comprehensive presentation. It's the country presentation and I will also touch on the TrueNut implementation as we had the IDDS project in the country to implement and pilot some sites. So I am from BRAC, Bangladesh. So it's a development NGO. It's a community-based organization and the largest partner of the National Tuberculosis Control Program in the country. So first of all, we can see the burden of the TB burden in the country. So as the incidence is 221 and it's already statics, and we can't hit still the incidence rate in the country. And based on our prevalence survey, it's 260. It has been reduced based on the previous estimation of WHO, global WHO report. Just a minute. No, he's telling something. Yeah, it's okay. Should I continue? Should I? Okay. So, and our mortality in the country is 25, according to the global WHO report per lakh population. And you can see the DRTB in new cases, 1.1%, and previously treated cases, 5.5%. And BRAC is one of the principal recipients of the Global Fund to implement the tuberculosis program in the country with the government. Yeah, so based on the last prevalence survey in the country, the missing cases in the country are mainly focused in the urban. Urban prevalence is higher, and high risk and underserved population, as well as the prevalence was much higher in the elderly or aged population, as well as male population than female. And the prevalence survey also showed, we also showed that the chest X-ray as well as the gene expert molecular diagnostics are effective tools to detect the tuberculosis for screening as well as detection of tuberculosis in the country. So these are the countrywide coverage. So BRAC is working with the government. So pink one is the BRAC coverage area, and other colors are representing the other partners with BRAC. With the government is actually implementing the TB control program throughout the country. So major activities we are implementing in the country with the government of Bangladesh and National TB Control Program is the active case finding activities like other countries. So these are community-based. We do some mobilization activities in the community with our community health workers in the country, and we do some TB campaign outreach as well as contact investigations. And we have some facility-based digital screening by X-ray, as well as molecular diagnostics in the facility. And we have some additional activities for some special groups. We call them key populations in the country, like children, elderly, pregnant women, slum dwellers, refugee, brickfield workers, minors, as well as prisoners. So we have our sample transportation activities. So we do transport the samples from the remote side to the molecular diagnostic sites for testing. And in the part of diagnosis, care and treatment, we have the linkage through testing facilities, and treatment, we have treatment supervision activities and follow-up activities at the community by the community health workers after identification of TB. And country or national program already started with the support of implementers in the community to do the ambulatory treatment for drug-resistant tuberculosis. And we have our patient support and incentives for duty providers as well as the patients throughout the treatment. And we are also implementing TPT in the country. Government is responsible for the technical support as well as the capacity building throughout the country and capacity building of not only staffs, also the providers from different level, from central to community level. And BRAC is also supporting us in some system, government system to strengthen the activities in the government facilities. So government is providing logistics supports to us throughout the country, drugs, cartridges, and X-ray films. All the supplies are ensured by the Bangladesh government to the implementers for implementation. And in the part of engagement of community and other stakeholders, we have some activities, courtyard meeting in the very ground level of the community, networking with healthcare providers, not only the formal providers, but also the non-formal like village doctors, pharmacy holders, and some traditional healers who are known to the community for as first point of contact. And private sector engagement, we are doing something through molecular testing and X-ray. We have mapping and listing of some private providers, and they are referring presumptive as well as cases to the NTP assigned facilities for treatment. And we have also some activities in the workplaces, and we have started some piloting on CRG and CLM related activities in the country. So diagnostic tools at TB diagnostic centers and community level. So in TB diagnostic centers, actually in the country, it's 622 gene expert machine throughout the country, but BRAC directly run 57 gene expert machine at the district level. Bangladesh has, as you have seen already, 64 districts, and we had since 22, 38 TrueNut machines we have piloted under the USAID supported IDDS project. So now, last year, these 38 machines are taken over by the government, and considering the good results from those pilot, actually government to scale up and more than 400 peripheral labs throughout the country, which are below sub-district level. So if we want to take these approaches to the community, to closer to the community people as patient-centered approach, so we need to scale up the molecular diagnostic tuners to the community, which is much more easier and cost-effective than for setting up than gene expert in the facilities. What is happening? Yeah, so for TrueNut machines, actually, we have sensitized, we have developed the capacity building of the staff. Not only that, we have also sensitized the healthcare providers in that sub-districts so that they can refer the presumptive for the testing. And we have portable X-ray in the country is 75 in total, but in the BRAC implementing area is 47. So we just started to implement through these portable machines and the screening in the community. So here the data is the notification rate. I have shown the 3 years data. So I will just focus here the treatment coverage part where actually if we see, if we want to hit the incidence, we will have to increase the treatment coverage in the country. So how is possible? So we have already seen that we have 221 per lakh population, the incidence in, and we are not able still to hit the incidence. So I think, and we are always at around 80% of the treatment coverage, but we will have to do it 90% and even more than 90%. So still need the diagnosis, early diagnosis, as Shahu has mentioned in his slides yesterday, that find, treat, and early diagnosis is the main support to do the more detection and increase the treatment coverage in the country. So this is the total case comparison. I am showing this because just wanted to show that in the last year, in comparison to last year, as we have actually increased the molecular diagnostic coverage, the cases is being increased in the first quarter of the 2024. Yeah. So just to show here the referral, I will not go much, but just one thing, if you see that the most of the cases are from the community, so we need to put, I want to echo with Dr. Sahu that we need to put those machines like TrueNut in the community to diagnose those and to increase the accessibility of those presumptives to be tested in the community. So then only we can actually increase the treatment coverage. So next slide. So these are the case detection in TB diagnostic centers, and we have some mobile vans is in. So I don't explain it much. So we can see the prison data. So one of our intervention, and we have just comparison data with 2023 that in first quarter 24, we are increasing as we are doing through mobile van. Mobile van is equipped with X-ray as well as we are doing X-ray screening with X-ray and testing with the gene expert. So the case diagnosis is increased in this area also. So one thing I want to show in this hazy slide that the comparative results with different testing methods. If we see that microscopy, gene expert, and TrueNut is very obvious here that through molecular diagnostics, we are actually identifying 2 times as well as 3 times than microscopy, the case detection and increasing in the country. So it's very obvious here to increase the molecular coverage for testing throughout the country. And the challenges, I would say that the scale up and optimization of optimum utilization of the molecular diagnostic is necessary. We all know, but resource is the main challenge. So we need to increase the domestic funding as well as we need to explore the opportunity as previously discussed for the other partners, USAID is there in the country, but we should explore further for other partners also. And I also echo with Mr. Aga that if we have guidelines and strategic plans in the country properly, so we can do that and we can propose to other partners also to support us in this regard. So, and definitely the uninterrupted supply of diagnostics and logistics is, I think most of the country are facing this. So we need to plan properly for these supplies, uninterrupted supplies of expert CAR-Ts, exafilm, as well as the reagents, as we are still using microscopy, LED microscopy in some of the laboratories. And the skilled human resource in place is very much required. So capacity building of the laboratory technician as well as the staffs who are working in the community or field level. So it's required very much the training and refresher training. And the reducing the dependency on microscopy for detecting TB, I already mentioned that the molecular diagnostics is the options for now to increase more and more cases and treat them to hit the incidence. And screening for TB presumptive in prison is also challenging still, but we have started with screening by X-ray and testing with expert, and the sensitization of private sector and sensitization of the private providers on those machines also, so that, and the sites, so that they can refer presumptives for testing to increase the case notification and referral. So I think I have finished here, but before giving thanks to you for patience hearing, I want to just recommend Molbayu senior management that actually a few days back we had a workshop with Molbayu. So we came to know that they are coming in with some portable special, I would say super special digital X-ray machine, what we can actually use in the community. And it's very good technology, handy, so smaller. So I think in that case, one of my recommendation to senior management of Molbayu to review the list whether these machines are enlisted in the GDF, so that it would be good and easier for the country, as we are taking fund from the global fund still. So I think if it is enlisted in the GDF, then it would be easier for the country to plan further for procuring those type of digital machines and to do the screening in the community. So thank you very much for patience hearing.
Thanks, Dr. Island, for your presentation. Here, you are the scope of the PR of the Global Fund for the so many activities for the Bangladesh TB control. Here, I would like to know about the. You also mentioned the involvement of the private sector. And the first question is how you are the NTP or your site to consider for the molecular testing at the private sector in Bangladesh context. As at government's MOH or NTP. The first question. Another thing is the how well you are the MOH or your Bangladesh context recommend the molecular testing as, for example, algorithm or the policy for the using of the gene expert testing or the TrueNet for the TB diagnosis. For example, criteria for the using mapping of the TrueNet at the site and which site or something like that. Yeah.
Yeah. So thank you for the question. So first of all, I think the private providers, we have done the listing and mapping of the providers at different level. Like the district level, we have 64 districts as well as the sub-district level. So we have that mapping with us. So not only BRAC, it's the actually it's not the duplication. The government is doing the central level, reaching the central level private providers like big hospitals as well as big public and private hospitals. So the orientation and networking is being done by the National TB program with those particular professors, associate professors, and the different medical bodies by the government, National TB program. So another one, then the district level as well as sub-district level, the implementers are also doing some networking with those providers. By this, they are actually referring some presumptives as well as in some times cases to us, and we are treating them accordingly as per national guideline. So this is one thing. And then for next question, then I have already mentioned that we had some criteria to specify and identify the places, and the based on like during TrueNat introduced in the places, we have considered the government for sustainability. Actually, we have considered the government facilities at the below sub-district. These are more closer to the community level, like Union Sub-Center we call them, like FWC, Family Welfare Center. So government has different infrastructure in the community level. So we choose all those and gave the priority to actually put this TrueNat machine in those facilities first for security as well as sustainability. That is one thing. We are just supporting with the human resource there, laboratory technician they are doing, and our community health workers are referring only because they are already sensitized as well as trained to refer the presumptive to those TrueNat sites. So that is one thing. And another one criteria we have thought before considered, that is the TB presumptive burden in the geography. So the TB presumptive burden where the most of the burden, so we consider those, as we have around 400 peripheral laboratories, but we prioritize 150 by that way. Thank you.
Yeah, thank you very much. Yeah, thank you very much for your very informative presentation. I have two queries. First one, you mentioned about facility-based digital screening. So were you targeting outpatient departments and were you screening all of them, or was there any triage based on symptomatic screening? And did you target any specialized hospitals for respiratory diseases doing empirical screening? I mean, digital screening. That is first one. Second one is, I think you've been doing, especially for pediatric case detection, stool samples for gene expert. So was it not Bangladesh? I'm not sure. Then maybe I can ask from the audience. So for TrueNat also, can we use stool samples?
Yes. Ma'am, for the first question, actually, we are doing it in the large hospital. Yeah, we have some screener like PPM mobilizers. They are doing the screening from the outdoor actually. And there we have the pathway. So after screening, if they think that these are TB presumptive, they are sending them to the hospital doctors in that department, which is from that outdoor. So after getting the concurrence from the doctor for testing, so doctor clinically examine that presumptive and then send to the send for testing. So that is one thing, and this is usually we are doing in the large hospitals. Yeah, and for the stool, I think actually the one of our partner, NTP's partner, ICDDRV is doing the stool examination. It's not BRAC still, but we are sending the samples to them for testing. Yeah, in different parts of the corners of the country.
Right. Thank you.
Just to add to her question, the question was essentially stool testing on TrueNat. So I want to inform everybody that the first study has successfully completed in Uganda. KNCV has completed the study, and it's the results are about to be published. The second one is already getting started in Nigeria. So we have, it's done. So to your question, we will shortly roll out the stool protocol commercially. It's already on the TrueNet.
So Shaila, wonderful presentation from my text. There are three small questions in a single form. Do you feel that after deployment of the 38 TrueNet, the case finding increased in Bangladesh?
Yes, definitely. I have already shown on slides, though so quickly that after introducing TrueNut, it's almost double. And the same center, actually, in previously when we were doing pilot, we had the microscopy also in the same center. We have compared those. So it was more than double. Actually, 7% the positivity rate, what we have done. So one thing is that case diagnosis, it has been increased, as well as it is a better opportunity for the community that they are diagnosed there as RR positive. So previously they had to travel from their home to the facilities, at least at the Upazila level or district level, but nowadays it's very closer to their home. So it's a very good opportunity and accessibility concern for the people of the community.
And Dr. Saila, another one thing that since TrueNet is infrastructure independent, so especially in Bangladesh, it is not the question, it is the country. So boat clinic type of thing.
Definitely, Dada. Board clinic, we don't think, but I have heard here.
Hard to reach.
Yeah, I have heard here, but definitely it's possible. But as it's just early stage and we are going to do this, I think we can. Thank you for your suggestion. I think we can plan accordingly to address all those hard to reach. But from 150 TrueNut, we have already addressed in some of our hilly areas. In those part, actually, we are transporting the sample to those TrueNut. You know that those hilly areas and some of the coastal areas is very hard to actually send one person physically to the TrueNut site, even it's too hard to reach. So that's why we are following these kinds of things, but we can think differently also. Thank you for your
last one is which is excellent kit for the extrapulmonary. So in this case, any kind of planning to implement, especially for the peritoneal, pericardial, or pus, or any kind of extrapulmonary samples which are over there in multi-specialty hospitals, private centers as well?
Yeah, thank you again for the suggestion. I think our line director sir is here. He already actually he's listening. So I think it's possible, definitely, but we are doing it through some expert machines, but hopefully we can plan.
Thank you very much. Thank you.
Thank you.
Thank you, Dr. Shaila. I think that was a good presentation. And I think what we have witnessed now in last few years, government of Bangladesh has come a long way. Like their commitment has been tremendous, and they have moved forward on the kind of point of care diagnosis and support to the people and community. And so I think this is a great testimony where once the government decides and they move forward. So I think kudos to both the government of Bangladesh as well as the associated organizations who are working with great. So I see that the energy is kind of going down, but there are 2 ways energizers. So 2-minute energizer. So there will be a video played here. And what we have to do is just what the video suggests, we have to do that exercise. So I'll request everyone to stand up and have slightly find a place where you can just move, right? A little bit up. So can you play the video now? Yeah.
So much fun with it's fun.
Yeah. So I think now with this, the a presentation from Ethiopia team. Sorry. Ethiopia is done. Sorry. It's from Nigeria team, but unfortunately, it will be a recorded video. And so what we can do is we can listen to the presentation in a recorded form, and then like the Nigeria team is also here, so we can kind of have a question and answer. So can I request to play the video? Thank you. I think this was really good presentation. Any team members from Nigeria who wants to add any additional comment? Yeah. Mike.
Good afternoon, everyone. My name is Michael. I wouldn't have much to add. What we see here is record stakeholder engagement from the onset. Systematic in term processes as the agencies once the most of those once we do that ultimately it's acquired and well we are all able to move forward in this.
But we are going to share briefly what we have done as part of scale up of the molecular diagnostic for TB, some of the successes that we've actually achieved, but also share challenges and way forward. Tanzania is, for those who probably don't know much of the geography, is located in East Africa. Our population is around 61 million. We are actually neighboring Kenya and Uganda, our fellow who have just actually presented as well. In Tanzania, we have around, yeah, so my slides are here now. Yep. So this is the outline of my presentation. I won't need to actually go through it because of time. Okay, so that's the map. Yeah, so briefly, I don't know if, yeah. So I'll briefly give you an update on what's the status in terms of ending TB strategy. And this is by 2025. And what you see from the slide there is the performance of vis-a-vis the target by 2025. As you see, in terms of the incident to cover, we're now at around 36%, and the plan is within the next, a year or so to reach 50%. In terms of death reduction, the target is to reach 75% by 2025. The catastrophic cost, this is the proportion of families that have TB cases that experience
household income due to accessing care for TB. That one stands at 45%, and we have a long go to get it to 0% by next 1 year and few months. Yeah, so in terms of the treatment coverage, we are now at 78%. We've done also a major progress, but maybe taking you through a few areas that we are still struggling. Patients who are tested using the molecular WHO recommended diagnostic tests. We are still at 47%. The plan is get to 90%. So this is where we haven't really achieved where we want, and we're probably not on track to achieve that within the next 1 year. In terms of TB coverage, we are actually making good progress. Another area where there is still a struggle is actually contact investigation coverage. We're currently at 50%. Also, in terms of coverage patients, and this, the denominator is all case cover in the next 1 year. In terms of documentation, we are doing good, but in terms of case fatality rate, we also have to decrease, to go down by almost 11%. In terms of TrueNut implementation, Tanzania started the implementation of in 2022. This was after the WHO recommendation, where working very close, as you see pictures of different events, working together with required users we also did to assess their readiness actually for implementation. We also did user training platforms during the phase 1. The adoption, the entire adoption process actually followed the GLI TrueNut. This was actually in collaboration with SDG and also NP. In the first batch during the implementation phase, we trained around 30 super users. Yeah, so these are the sites. We have almost strategic plan is now aiming to reach. So we hope that the TrueNat platform will be one of the we are get in the next more support are coming from the funding for was actually done and hoping that during okay. $2,572. And out of these 83, almost 84% were successful tests. So that makes around 16% of unsuccessful tests. We were able to detect MTBC, the complex strain, were not detected in around 90% of them. However, around 10% of them were detected. And in terms of reef resistance, were not detected in almost 71.8%. And we detected actually the resistance in around 3.1%. And the MTBC detected reef resistance, rifampicin, in 30 minutes was 25%. So this, the denominator here were those who were MTBC detected among the successful tests. So general achievement, actually, we, as you see, after implementation of the TrueNet or introduction of the TrueNet, we've been able to actually increase access to molecular TB testing and also the drug sensitivity test, where the coverage now is increased by 3%. We are in collaboration with actually DMBP Medical Group, which is the mobile distributor within the country. The NTLOP, the National Program for TB, has been able to provide technical assistance to sites that are actually using the TrueNet by providing troubleshooting, but also remote and physical support mentorship within the existing 30 platforms. And at the moment, all of them are working in a good condition, are functioning well. We've also enrolled all of these sites into the National EQA program. And we've also conducted the TrueNet implementation evaluation to inform now the strategic scale-up, of which the 110 TrueNet machines are going to be part of it. So what are the challenges? We have also experienced unreliable means of collecting, monthly key performance indicators from the testing facilities. And this is mainly due to challenges within the existing data system, but also the low bacteriological confirmed PTB. It's 40% versus 70%, which is the target. So there is a big mountain here to climb. Also, we've observed some high invalid rate in some of the TrueNet facilities, with an average going up to almost 13%. And also, as it has also been discussed before, the stock out of reagents, which sometimes has caused really not, unavailability of the testing services. So some of the recommendation here is now to, strengthen the connectivity through the digital solutions for real-time KPIs. We want to also improve access and coverage, and then also enforce the correct use of the algorithm. We are going to strengthen actually our collaboration with Molbio partner and other implementing partner within the country to train reliable TrueNAT users and regular on-site mentorships to facilitate with suboptimal performance. And this is because, as you know, there is also, the turnover, of also some of these workers who are trained, and at times it's important to also make sure that you have more than one, staff who are trained on using this, so that whenever there is, a rotation or somebody has been placed somewhere else, there will be a backup person to also continue making sure that the platform is being used. Yeah, and last is to actually implement timely quantification and forecasting of TrueNAT reagents to avoid any interruption in the process. Some of the lessons learned that we've learned is actually adoption of the new technology. It requires comprehensive collaboration between the government, donors, implementing partner, and all stakeholders. And I think this has been discussed in almost all the presentations here. The optimal test performance, it depends on the availability of qualified staff at the facility, and also readily available of technical persons to actually provide timely and proactive TAs as needed. Clinician training is also important, and this can be training or rather sensitization to just make sure that there is a good understanding of the machines, the platform, and how they can actually be used so that we optimize their use. And we think that this is important to be done in parallel with the training to ensure that the clinical and the lab interface in the diagnostic cascade is being optimized. Also, collaboration with the local partner has been one of the key factors in the success during scale-up of this TrueNAT technology. So as the next steps, once the 110 devices have been delivered, we're planning to conduct the systematic site readiness assessment, users comprehensive training, and subsequent devices installation in collaboration with Molbio. We also plan to conduct TrueNAT implementation feasibility study for its utilization beyond health facility. In collaboration with also Molbio representative, we intend to organize a sensitization workshop to all relevant implementing partners on the use of the technology to embrace sustainability and ownership. We also aim to explore opportunities and feasibility to use the technology in other assays or specimens, e.g., for example, the news that we've just received about the use of stool for TB, HIV, hepatitis, and other possible tests. Pending the experience and technology performance, we intend to continue actually procuring more devices to saturate the 700 molecular diagnostic, which is the target by 2025 as outlined in our current national strategic plan. That is all I have from our team, and thank you for listening, and happy to respond to any of the questions. Thank you. And just before, I have a team of experts with me that will be more than happy to also share responding to those questions. So none of you who is sitting there is immune from those questions. So thank you.
Thank you, Henry Ghana. How easy were you able to integrate the TrueNAT system into the EQA?
Thank you. Sam, do you want to say something about that? And then I can.
Yeah, thank you. As my colleague presented, we had a stepwise adoption of the TrueNAT devices and the technology as a whole. And as a matter of fact, we were also keen to understand how are we going to ensure that the quality is, of course, undertaken on board. we collaborated with the USAID IDDS, whom they provided us with the support in collaboration with the Smart Spot from South Africa. We enrolled all those devices into EQA program. And before letting them start performing EQA, we did a sort of collaborative training, the technical team from the country and actually the experts from the provider. And we had a initial performance for the EQA, and gladly the outcome were good. And from the first, we did the two cycles. The initial phase had suboptimal performance, and from it we learned that there were some challenges that we deployed specific interventions, and for the next cycle we observed the actually improvement. This speaks to that the EQA portrays the whatever the processes which are suboptimal and give us a chance to actually improve them in a focused manner. Thank you.
Thank you, Team Tanzania. I'd like to ask on TPT, has it been accepted and what is the uptake? And my second question will be based on the answer, but I can as well give it. Don't you have fears about AMR with TPT use or misuse? Because usually if someone is not ill, they tend not to complete their treatment. How are you working on that? Do you have any surveillance, or how are you managing the AMR concern? Thank you.
Thank you so much. Yeah, so the TPT, and I will let maybe my colleague also add, we have a large program of TBT, and it's really integrated within the HIV platform as well, within HIV TB co-infection. And at the moment, we have a large, I would probably say over 80 to close to 90% clients who are eligible. So we have the eligibility criteria for those who are supposed to be started on TBT. And the uptake has been quite well. We've had now challenges, especially, for the past few months, especially with the transition to the shorter regimens, that we've not, been able to get the required amount to sustain those who were either on TBT or those who were actually supposed INH, and those who were actually starting, so that they are started on the right shorter regimen. But we also have so in terms of the surveillance for AMR, we have several initiatives that are actually doing surveillance for antimicrobial resistance. And so this is one of those that actually are incorporated within that platform. We have a funding mechanism that involve several academic institutions, research institutions that conduct AMR, and this is part of the included platform within it. So definitely the fear is there because with the dropouts and sometimes poor adherence, there's definitely a risk for AMR, and we continue to actually strengthen measures to improve adherence, but to make sure that we integrate TPT as part of the continuous surveillance activities that are done. I don't know if I've exhausted it. I don't know whether.
Yes, just to add on the MR, I think recently the government has noted that verticality has brought us into many problems. So actually what they did with the MR particularly, they've actually identified some key members from the TB programs who are actually joining the MR Surveillance Technical Working Group, where we discuss MR issues on actually the defined time. But within that, we have the actions that are collective, taking into action that TB is also one of the MR, which is actually more serious than other diseases. Of course, in the technical group, there are multi-sectoral approaches with the One Health approach, which is also included in. Thank you.
Actually speaking, when you treat latent TB, it's a dormant bacilli, does not multiply. Chances of AMR are practically nil. That's well documented. There are various research publications of this. It's less than 0.00 some percent. So antimicrobial resistance with TPT is not an issue. Don't think of AMR on dormant work. Yeah, we'll share. Of course, you start treatment only when you rule out active TB. If there is no active TB, don't think of AMR.
Oh, good. Thank you so much.
Thank you, Dr. David and the team. So we decided to taste the endurance. And so we will have one more presentation now. And so we are a big team, right? So so that's the last presentation what we will have from team from Zambia. And I'll request Mundia Kangonwe to just make a presentation. And we'll request really to be brief and to the point so that we can kind of break for the lunch.
Good afternoon. Good afternoon. Okay, I'm Agnes. I'm from Zambia, Straton Life Sciences Limited. I would like to share the good news is that Zambia was among the countries that we started with the evaluation process. So finally, I would say the evaluation process was completed and it was successful. The TrueNet is now finally adopted in the country. Thank you so much. So with me, I have Mr. Mundia, who's going to present the recently passed evaluation results. Thank you.
Good afternoon, everyone. Greetings from Zambia. Okay, so as I have already been introduced, my name is Mundia. So I'm a biomedical scientist by training with an MSc in medical microbiology. I was the immediate past research officer at the National TB Reference Laboratory, and I was the lead principal investigator in our evaluation for the TrueNet. I also lecture at the Leifman Wasa Medical University, which is the largest public medical school in Zambia. So a diagnostic network assessment was actually conducted by our national TB program. And with that assessment, a gap was identified in those areas which are hard to reach, in that they lacked capacity to, rather they lacked capacity, they lacked access to WHO recommended molecular rapid diagnostic tools, such as the Expert as well as the TrueNet. So we are aware that Expert MTB Reef Ultra and of course the TrueNet are WHO recommended as first-line diagnostic tool for all those patients which will present with signs and symptoms of TB. So following that gap assessment by our TB program, actually prior to the assessment, we also adopted the Expert MTB platform as our first-line diagnostic tool somewhere around 2016. So we've been having the Expert from around that time. But then with the assessment which was done, of course, a gap was identified in the sense that the expert was not able to actually reach out to all the diagnostic sites. Sorry. So this is the profile of the network for TB diagnosis in Zambia. So in total, we have 492 sites which are performing TB diagnosis, out of which we have 302 which are covered by experts, expert platforms, representing a coverage of 61.4%. Apart from the expert, we also have 30 sites which are covered by TB LAMP, and then we also have 106 microscope sites. So there is a call by our TB program to actually increase coverage to somewhere around 80% by 2026. And from the results which we are seeing there, we can see that in 2022, those tests which were performed by experts were somewhere around 302,761, compared to the 2023 figures showing about 446, close to 500,000. There was some upward trend of about 2% in terms of tests that I performed. So that's the picture. So therefore, with this evaluation, we are also aware that TrueNat has already been endorsed by WHO for first-line diagnosis of TB, presumptive TB. But we had to do an in-country evaluation, again, as per recommendation by WHO. So we did some bit of a robust evaluation. It is also part of our Ministry of Health requirements for any new platforms before they are adopted for use in the country. So those are the objectives which we had for this particular evaluation. So the general one was to evaluate the diagnostic accuracy of TrueNat MTB Plus, and of course the MTB RIF assay for detection of MTB DNA, as well as resistance to rifampicin. With the specifics, we wanted to see the diagnostic accuracy of TrueNat, both in detection of MTB, DNA, as well as detection of RIF resistance. And then from there, we went further to evaluate it in our clinical samples, which were from presumptive patients. And then there we're trying to see how concordant the results we would find for TrueNat versus our currently in use expert MTB RIF Ultra. Then we also thought of just trying to assess the error rate for TrueNat as one of our specific objectives. So that's the sample size which we use, and also the plan which we used. So we had a panel of 105 culture isolates. These were actually from midget culture. And then we had to re-verify them on expert MTB RIF. So more or less like we're using a composite standard of culture and expert MTB RIF. So for that particular design, we're trying to evaluate the diagnostic accuracy of TrueNat vis-a-vis sensitivity and specificity. So that panel of 105 isolates were comprising of 55 rather confirmed MTB isolates. We also had a panel of 50, which we used as our negative panels. Those were culture negative, and 5 of them were actually non-tuberculous mycobacteria, to try and see if we could have some cross-reactivity among the mycobacteria between MTB and the non-tuberculous. So in addition to that, we added some clinical samples, like our area alluded to, clinical samples, which were consecutively tested and then parallel tested also on expert. So those were actually initially meant for TB diagnosis. For those patients who were coming in as presumptive TB cases. So we split the sample. Part of the sample went for routine diagnosis with our expert, and part of it was taken to TrueNat for evaluation. So the study was conducted in 2 sites. the National TB Reference Lab, as well as the UTH, which is the teaching hospital, TB laboratory. So both labs are actually reference labs, and then they are both also ISO accredited. Then the period was about October to December last year. So this is just the inclusion and exclusion criteria which we undertook. So we wanted samples which were basically at least 3 meals and above for the sole reason of having them to be split between expert and TrueNAT. Then we also only tested adults, we excluded children. So those were on ATT were excluded. We didn't perform an evaluation using extrapulmonary TB samples. Then the performance acceptance criteria, for the first component, which was diagnostic accuracy, we sort of set it a little bit high in the sense that we're using isolates which are already confirmed. So we want to see how best we can actually achieve the desired results with our TrueNAT. So we set it at 95%. That is what we thought could be acceptable. Then on the clinical samples, so we went for a concordance of about 100% between expert and TrueNAT. So that was just like the layout of our analysis plan. So we use some online statistical tools to analyze our data. So we computed sensitivity and specificity using VersaStats, an online tool, so that we're able to compute our sensitivity and specificity. When it came to our agreement rate or concordance, we use another tool called Kappa's online calculator. Okay. So then these are our findings. So I've put them like as per objective. So the first objective was to assess TrueNAT in terms of detection of MTB from the panel of non-isolates. So with this, out of 105 isolates which we had, 55 of them were confirmed TB positive by expert. And then out of the 55, TrueNAT identified 54. It missed one, and then the other one was what we considered like a false positive. So when it came to, or before I go to the specificity, so then that gave us a sensitivity of 98.2% with a confidence interval of 89 to 99.9%. So then coming to the specificity, out of the 50 which were confirmed by expert, TrueNAT was able to identify 49. And then that gives us a specificity of 98% with a confidence interval of 88 to 99.9%. Moving. Okay. Second objective was to evaluate TrueNAT with regards to detection of reef resistance among the panels. So out of those 55 panels of MTB, so 23 of them were reef resistant, whereas 23, also 31 were susceptible. Good enough for TrueNAT was able to identify both the reef resistant and the reef susceptible. So giving us 100% sensitivity as well as specificity. The third objective was to evaluate performance of TrueNAT vis-a-vis detection of concordance in clinical samples. So in the clinical samples, out of 110 samples which we evaluated, 6 of them were invalid, so we had to actually do the evaluation on 104. So from the 104 samples which we tested, 14 of them had MTB detected, rather 17 were MTB detected by our reference standard expert, of which TrueNAT detected 14. So that gave us a 96.2% concordance or agreement rate. Yeah. So out of the 14 which were MTB detected by TrueNAT, so those were then taken for MTB reef detection, and then we had 2 of them which were reef resistant as identified by expert. So the same was also with TrueNAT. So thereby we had 100% concordance in terms of reef resistant detection. So I think I should be winding up. So the last objective was to determine the error rate of TrueNAT. So like I earlier said, we had 110 samples, presumptive samples, out of which 104 were successful, giving us an error rate of 5.6%. So this just like to try and see like what others did. So our findings were actually consistent with what was found in other studies like in Cameroon and Ethiopia. Though we had studies which were performed in other countries which showed lower sensitivities, like a mouse study in Ethiopia, India, Papua New Guinea, and Peru, as well as one also in Uganda. So the same applied to specificities. We had some which had lower specificities compared to what we found. Also, in terms of rates of error, we had higher rates which were reported in Uganda and Ethiopia, 7.6% and 18.4% respectively. So in conclusion, we were able to deduce that and conclude that TrueNAT assays actually are very good, robust in terms of detection of both MTB and reef resistance, both in clinical isolates and presumptive TB cases. So therefore, I think they are good for us to use in Zambia. And to that effect, the Ministry of Health, together with our national TB program, have actually adopted the TrueNAT as earlier alluded to by Agnes. So as recommendation going forward, we thought we could perform some further evaluation in the implementation phase, just to see how the platform performs like in the rural settings. As I had earlier said, the evaluation was done at 2 reference labs. And then since the intention is taken to those hard to reach areas. So then we can see how it can perform in those areas. And also in people living with HIV, as well as children for which we had not done the evaluation, and also with extrapulmonary TB cases. So this is in the implementation phase. So acknowledgements, of course, Mobile Diagnostics for making it, for inviting me to be here to come and present this work. And of course, not forgetting the mobile partner in Zambia, the sole distributor in Zambia, Stratton Life Science. And of course, the Osaka Provincial Health Office, where I currently work as the provincial biomedical scientist. And then the National TB Reference Lab, where I just exited a few weeks ago. And of course, the TB program at Ministry of Health. Then the University Teaching Hospital TB Lab, where the study was actually conducted. Thank you so much for, before we end there, I think I just have some pictures here to show. So this was the training which was actually conducted in Zambia. So that is the team which was conducted, which was the actually trained in Zambia at the National TB Reference Laboratory. Then the next picture is just showing us there was a visit at the University Teaching Hospital TB Lab. So there we can see our professor there in the picture, Yvonne there. Of course, Agnes, our partner in Zambia for mobile. We have Dr. Solo there on the immediate right, who is actually the head of the TB lab. And then the last picture there is just showing us the showcasing of the TrueNAT at the World TB Day commemoration. Thank you so much once again. Okay.
Yeah, so house is open for very quick comments and questions. Yeah.
When it was introduced first in your country in 2016? Just curious to know.
Okay, thank you for that. For the gene experts, apparently, as far as I know, when it was first introduced, the evaluation wasn't actually done from what I know. I think it was just like rolled out. Yes. I think the more reason to that is that I think there were not much mechanisms in place in terms of maybe these evaluations, the aspect of quality management system. So I think that came on board a little bit later. So now it's Ministry of Health policy for any platform that is entering the market to be evaluated before it's actually adopted for use. Thank you.
Sorry, I was just curious, given the fact that Zambia was privileged to evaluate this platform, any plan for rolling out in the use for public testing?
Yes, so like we have indicated that after the evaluation, so the Ministry of Health has actually adopted. So the plan is there. It's just that I cannot kind of maybe delve into that because I'm not on the program side. But I'm aware that I think there should be some ongoing, what can I say? Like the plan is already there in place because even with the guidelines which we currently have, TrueNat is actually in the guidelines already. So I think the plan is in place. Yeah. Sure.
Yes, I also stand to be corrected. I just have a comment. I know you were comparing TrueNat against the GNS, but I know in most of the studies where similar thing is done, it is not comparing TrueNat against the GNS, but they compare both against a gold standard, which is culture. How do you then answer this, please?
If I got it correctly, so you are implying that the evaluation or comparison should have been with the gold standard of culture and DST, as opposed to TrueNat and expert?
Yes, for the past studies that I have reviewed.
Okay, so like I earlier said, the first part of it for diagnostic accuracy, we actually had a composite standard of culture isolates, which were basically confirmed on expert. So in other words, we had culture and expert combined.
That all? Yeah. Okay. Thank you. So thank you so much. And I think with this, we are coming to the end of the marathon. Thank you so much for bearing with us. So now I will hand over to the organization for the next part. But had a great learning and thank you so much.
Thank you, Dr. Shah, for steering the marathon so deftly. And thanks to each of the participants and presenters, for sharing their country's experience and their own insights for deploying point-of-care molecular diagnostic tools. Special thanks to Dr. Samantha for inspiring all of us with her never say die attitude. Behind every scientific new tool invented goes the human brain, more brains than one. Behind making a plan for deploying them for public health use also go the human brains. But for implementing the plan at the grassroots level, you have to combine the heart with the brain. And definitely, we need, in the end, the dedication of the likes of Dr. Samantha to help us travel that last mile in our journey to end tuberculosis. Thank you for your attention. We now break for lunch, and I would request Dr. Bianca to tell us when are we going to be back here in the room. I think it's almost 2:35 now. Oh, not even half an hour? Okay, thank you. Yeah. That's better, I think. 3:15 dot, we are back here. Thank you.
million death due to TB by 2030, and TB-affected families facing catastrophic costs due to TB, bring it down to 0%. So what are the factors related and what can be done and what needs to be, So some of the UNHLM targets for 2027, this was adopted in 2023 during the UN high-level meeting by all the world leaders. And I think we really need to look at this. One is reach 90% of estimated TB patients with diagnostic and treatment services and health and social support, which includes, all of what we talked about. 100% of those tested for presumptive TB should be done upfront with a WHO recommended molecular test. This was the second target. Third target is 100% of people with TB have health and social benefit packages so that they do not face any catastrophic costs. To treat at least 45 million people between 2023, where we have very little time left. We are already in 24, 25, till 27. Treat 45 million people, including 4.5 million children and 1.5 million people with drug-resistant TB. 90% of high-risk population, those eligible for TPT, should get TPT. So the target includes 45 million people, 30 million of those household contacts, and 15 million living with HIV. Integration of TB response with other health programs like HIV, tobacco, NCDs, mental health, alcohol control, nutrition, many others, and of course, many more, but there's already some food for thought here. And so when we're discussing, we'll all gravitate towards these numbers and look at what are the solutions. Now, to do all of this, we're going to break into 3 groups. So to have a more equal distribution, we're just going to call out numbers between 1, 2, 3, like as we go along. And when the number that you've called out, that is your number. Group 1 remains in this hall. Group 2 will go to Regency 1, and Group 3 to Regency 3. There, when Sir will also explain how we would like to do this, you have to designate one, a rapporteur who collects all the notes of all the discussions, one, a timekeeper, and somebody also to present, which means that the one of you have to have either a computer to write it down, or you want to do it in a kind of a presentation format. Let us know if you want to just use, or talk without a presentation. That's up to you, but preferably a PPT. So somebody in the group should have a laptop who can quickly write these points down. So how many slides are we looking at for each group? 3 slides? You think we can fit? All right, let's try. And 3 to 5 slides, maximum 5 slides per group. Okay, so yes, you had something, sir? Okay, so 5 slides after the discussions. And of course, your facilitators will be there to help you to go through the questions, have a discussion, take lessons from your country, and share it with the group, looking at the global aspect on what is really required. Now, the whole point of doing all of this is also because, as you see, that we would like to draft a statement that is going to be discussed with you, agreed with you on what you feel the need is. And we would like to submit this to Stop TB Partnership, WHO, for the next UNHLM meeting. So another point which is very, very important here is to be able to continue, because I doubt we will be able to do this in 2 days where we'll have a nice, good enough statement. What I would really like you to do is, if you can, so you see there are 2 QR codes at the back of the room. One is on the whiteboard and another at the back on your way out. One of them is to give us your contact details. You just have to scan it and fill up a form. This is very important because we need to be sharing emails and going, based on the statement that we've come up together. so that we can have changes when we go back home and then we've had some time to think about it. So then, and that's why it's very crucial that you have your email ID there so that we can send a common email. Bobby will coordinate this with everybody so that we have a group that has discussed and agreed on all of these, suggestions, and that will be endorsed by everybody. Is that okay with everybody? So one of the QR codes, just scan, fill in the form, and that is, we're going to use that for communication. And I think we will be, don't worry, I think when there comes a point when there's a consensus with everybody that, okay, this is a statement that can go, then we will stop the group emails and keep you updated on when we submit. Yes? The other QR code is more for tomorrow at the end of the training, so I'll explain that later. Some of you have not signed the endorsement to Global Call to Find All TB, to NTB. Please do. It's there till tomorrow. And also during discussions, like for example, we had very limited time to ask questions, to put our thoughts across. Maybe a few of us did not get the chance. Please use those sticky notes and stick it on that wall. Believe me, we will include those notes in as well. Which is very important because everybody's voice should be heard, and we would like to include it all. We've also received requests from a few countries who could not present. What we've requested is if you can give us your PPT. That is, I think, Malawi, Sri Lanka, and a few other countries who've made a request. Please give us your presentation that you have. We will see tomorrow at the end of, after our panel discussions, if we have some time to, talk about it. But there were also a few other countries that we've received inputs from that we are going to share with you on a PPT, Bobby and I. No, Bobby? Yeah, and that's what we're going to share tomorrow. So you still have, please give us the chance to be able to present for you. And tomorrow we can always take questions. Everybody okay with that? Okay, so for the group work, since we are now very much, yes, we actually, there was a lot of, okay. So should we do just 1.5 hours of discussion and then we come back, do a final thing, and then we close for the day? Yeah. So before we all get out to the groups, I just wanted to announce for tonight, we have a gala dinner, which is being organized in Alila Divas. For those of you staying there already, you know where the hotel is. The bus, after the session today, the bus will first take the guests who are staying at Alila Divas, and then it will come back and pick up the other guests who are here in Kenilworth, okay, for the dinner. Right, so shall we make groups? Everybody just, 1, 2, 3, starting with Henry.